Yep, whenever you're ready.
Yeah? Okay, all right, thank you. Okay, good afternoon and welcome everyone to the afternoon sessions. I'm Prof. Chong Pei Pei. I will be co-chairing the sessions for this afternoon together with Dr. Vivian Andaya Verbo. So the first part of this session, which focuses on the topic of primary care, will run from 1 p.m. until 2:30 p.m. We'll be hearing from our invited speaker and two oral presenters highlighting their research in this field. The next part, which focuses on occupational safety and health, will run from 2:30 until 4 p.m. There will be an invited speaker and two oral presenters as well. Following that, we will have talks covering the diagnosis and treatment of COVID-19. During the talks, you may also pose questions to the speakers online through the Slido using this code. The session will end by 5 p.m. So let's get started. And the first speaker that I would like to invite is Dr. Lee Kai-yin. Dr. Lee currently teaches clinical pediatrics at the National Defense University of Malaysia. He's a pediatrician by training and a proud father of two children. During his 11 years tenure with the Ministry of Health before joining academia, he served in both rural and urban areas, as well as underprivileged communities such as Orang Asli in Perak and Penang in Sarawak. He believes in community empowerment and the power of communication. He teaches his students to not merely treat diseases, but to treat the person who has the disease. So, welcome, Dr. Lee.
Thank you very much, Chairperson, for your kind introduction. Once again, my name is Dr. Lee. I'm a senior lecturer in pediatrics from the National Defense University of Malaysia. I would like to talk about the impact of COVID-19 pandemic on holistic child health. A quick disclaimer before I begin with my presentation. This is the content of my presentation today. I will start off by introducing the certain terms and dive into the impact of COVID-19 pandemic on children's physical health as well as psychosocial well-being. Then I will touch on children living in poverty, and lastly by finishing off by discussing what we can do and the future challenges, as well as to conclude my presentation. As an introduction, a child is defined as a person who is less than 18 years of age. Now, this is not only the definition used medically, but also in law as stipulated by in the Child Act 2001. While the term holistic is often used in medicine to describe the management of an individual as a whole, and lastly, the World Health Organization defines health as a state of not merely physical health, but also mental and social well-being. This definition has not changed since the 1950s when the WHO was first established after World War II. I would like to first dive into the impact of COVID-19 pandemic on children's physical health, and I will discuss this based on these four titles, namely a pediatric COVID-19 infection, pediatric inflammatory multisystem syndrome, or PIMS for short, nutrition, and lastly the provision of other health services. Let's start off by talking about COVID-19 infection in children. Ironically, this is probably the easiest to discuss, really. Huh? Well, as we all already know by now, COVID-19 seems to affect predominantly the adults, especially the elderly. So the proportion of infection among children is relatively small. It's about 5% globally. And the symptoms also in children are very similar to that of an adult, which is mostly mild respiratory or gastrointestinal symptoms, ranging from fever, cough, lethargy, diarrhea, and so on. Okay, now these symptoms tend to be mild and fortunately for children, rarely needing intensive care or causing mortality. However, this is very important for us to understand that around 20% of infected children are without any symptoms, meaning they are tested as part of the screening, for example, but they are well. In fact, some of the more recent studies even quoting as high as 50%. Okay, this is important to understand. The implication of that is that while children may not be having severe infection per se, they may contribute to the community spread and act as reservoir for the virus. Okay, so albeit rare, but children can die from COVID-19 infection. So the at-risk group would be the young infants to less than a year old, and the children with pre-existing conditions such as congenital heart disease or polycontrol asthma. Secondly, I would like to highlight a condition called PIMS, okay, a pediatric inflammatory multisystem syndrome, which is said to be an immune-related condition occurring weeks after the primary COVID-19 infection in children. Now, some of you might have read from the news or heard about Kawasaki disease caused by virus in children, especially in the UK. Suffice to say, there's still a lot of unknown surrounding PIMS, and while it shares many similarities with Kawasaki disease, it is now being identified as a distinctive condition. Now, the picture on the right over here summarizes a feature of PIMS. Now, for those of us who are familiar with Kawasaki disease, which we do see in Malaysia often, the common features are, for example, fever tend to be long, more than 4 days. There would be red eye or conjunctivitis, red lips, okay? And some of the swollen lymph nodes on the neck or cervical lymphadenopathy, yeah? Okay, it's also important to note that the majority of those who develop PIMS, that is from UK, they were previously healthy. Okay, a recent report from the UK has seen a surge in PIMS cases. As far as I'm aware, we do not have yet have any data locally. Let's move on to nutrition. Back in 2019, when the National Health and Morbidity Survey was released, we within the fraternity of pediatrics was shocked to hear that 1 in 5 Malaysian children are stunted. That is to say that they are deemed to be short and not thriving in accordance to their age. But sadly, the pandemic has only worsened the effort to reverse the trend. Now, firstly, many nutrition-related services are disrupted, okay, starting from antenatal counseling, dietary counseling, or postnatal nutritional counseling, or supplementary feeding counseling, as well as the more specialized dietary counseling for children with failure to thrive. Now, secondly, many children from the low-income household depends very much on the free breakfast program provided in schools as a main source of nutrition. Closure of school therefore means that they are potentially missing out a third of their daily nutritional intake. Now, lastly, before the pandemic, food security is a major issue in Malaysia, especially again among the low-income group, and they are the ones that will be hit hard by the pandemic. Okay, so the ability to put enough food on the table for growing children has only become harder. The pandemic also causes major disruption in the delivery of other child health related services. Take immunization, for example. We have seen a drastic drop in the uptake of immunization, especially during the first nationwide MCO back in March last year. If you look at the chart on the right, courtesy of Dr. Zulkifli, back in March, April, and May last year, the uptake of the measles, mumps, and rubella or MMR vaccine has dropped for almost 60% when compared to the year before. And furthermore, the services that rely very much on face-to-face sessions, such as rehabilitation and palliative services, face a major challenge during this time. Now, children with special needs are particularly affected. Now, take for example, children with autism, right? They rely very much on occupational therapy or speech therapy, which has been a face-to-face session. Okay, so this has really affected their rehabilitation. Okay, even other core services like the child health clinic in clinic kesihatan, or the pediatric specialist clinic in the hospital, or some of the non-urgent procedures. Just take for example, hearing tests are either postponed or downright cancelled. Now, on the other hand, anecdotal data shows that admission rate to the pediatric wards in the hospitals has reduced. Now, presumably because children now stuck at home, they are healthier. We have to understand that what is good for prevention for the prevention of COVID-19 is also good for the other communicable diseases like pneumonia or diarrheal diseases, just to name a few. Right, I would like to now move on to discussing the impact of COVID-19 pandemic on children's psychosocial well-being, and this is a lot tougher for us to discuss. Again, I would like to highlight these 4 areas for discussion, namely the mental health, child abuse, social media and internet use, and lastly, education. Now, let's start off by talking about the impact of children's mental health. The National Health Morbidity Survey, again in 2019, highlighted the fact that almost 500,000 Malaysian children are suffering some kind of mental health problem even before the pandemic strikes. Okay, so when we are under lockdown, we're under various phases of MCO, the first effect that we often hear would be cabin fever, right? This is a feeling of being trapped within the house, and it can manifest as restlessness, irritability, and intense loneliness. By the way, it applies to adult as well. Yeah. And being children, they will inherently have limited capacity or ability to understand the reason behind lockdown. They will ask questions like, why can't they go to school? Why can't they play outdoor? Why can't they meet their friends? Right? So this anxiety is further exacerbated by the need to adapt to online learning, which is very, very tough. For those of you who have children at home, you would definitely understand. Huh? A recent survey from an NGO, the World Vision Malaysia, has found that almost 70% of children experience some form of punishment at home, physical or psychological, and almost 20% or 1 in 5 reported severe level of stress being trapped at home. Of course, the most severe end of the spectrum of mental health would be mental illness, namely major depression. Okay, so some of the children can even have major depression or even suicidal thought. Now, moving on to the impact of pandemic on the prevalence of child abuse. Recently, the Interpol has released a statement highlighting a trend of underreporting of child sexual abuse globally in the midst of pandemic. And because we are largely confined to the home and internet and IT devices, there has been an increase in the sharing of child exploitation material through dark webs or even social media. Now, in contrary to the Interpol statement, some NGO locally who are involved in the groundwork of child abuse has experienced heightened level of reporting and help seeking among children, while Bukit Aman also seemingly reported increased cases of child sexual abuse, especially that the perpetrators are often someone who reside in the same house. Next, the use of social media and internet among children during MCO, when now even schools takes place virtually, right? So there has been a rise in the internet content addiction, particularly social app, video streaming website, and online gaming. So increased time spent online also means opening up more opportunity for cyberbullying. Something as simple as receiving a text message through WhatsApp, for example, from a friend that you are ugly, you are fat, is considered cyberbullying, right? And as mentioned earlier, there has been an increase in child exploitation, sexual exploitation, dark webs, and circulation of some pornographic material. And more worrying, And more worrying to the trend is that we found that many children who use the device are unsupervised, and for those of the children who face negative influences when they are online, they tend to keep them to themselves and refuse to confide in their trust figures. Now, these are just some of the reports that might have read. Okay, so online classes had to be stopped because a Form 1 student was found to be watching pornography. Now, I want to highlight here that, well, we should not victimize this Form 1 student, okay, in this particular example. So we have to read it that this particular student, young 13 years old student, is considered a victim of sexual abuse as well, because he or she was, has to gain access to this pornographic material from somewhere. Someone may have accidentally show it to them, for example. Yeah, so this is something that I think we have to consider. Okay, and the documentary by RH, the Rage, titled Predator in My Phone, was actually published in 2016, which tells the story of sexual predator using social app. So I really urge all of you to watch the documentary online. Okay, these are just some of the social application we are very familiar with. And these are just some of the examples of popular online games that our kids are playing. The last topic I want to touch on is education. Now, we all have read the news of poor internet connection and shortages of laptops for online classes. Students are found to be climbing trees or gathered in shacks with terrible conditions just to get better internet signal. And the ability to gain stable internet with sufficient IT devices really highlight the digital divide that we are now in. But having the facility is only a part of the equation. Many teachers, myself included, are struggling to deliver our content virtually. Students, on the other hand, often find it difficult to focus, have low motivation, but plenty of distraction during the online classes. Okay, we must also remember that school is not merely a place to learn academic stuff, but also a place whereby it provides a holistic environment for their personal growth and development. Okay, so the worst affected group, the group of children that I've encountered are the ones who face abuses and neglects at home, and there have been regarding the schools as safe havens or even refuge. So they are the one that now really are being trapped at home with the perpetual cycle of abuse. A few words on poverty. So it's defined in Malaysia as having family income of less than 2,208 ringgit per month. As of the statistic in 2019, 5.6% of Malaysian populations are living in poverty. Okay, and it's expected that the pandemic will push another 5 to 8% of household into the downward spiral. Right, this is according to a medical center survey. So we are looking into more than 2 million children living in poverty by the end of the pandemic. And the sad fact is that they are the ones that are at the highest risk of suffering from all negative impact that we have discussed so far. So these bear the big questions of what we can do, not only at personal level, but also as a family, in the community, and as a nation in a whole. As a whole. Right, before we touch on things that we can do, let's consider, is there any positive changes out of the pandemic? Well, there are many, but these are just some of the things that I can think of. Now, as I mentioned earlier, so we have seen an overall reduction in infectious diseases among children, and therefore a lower rate of hospital admission. And for some of the more able parents, we have seen increased time spent with their children, which often before the pandemic time, they would normally send their children to daycare center, for example. So this increases the time for the bonding. Okay, and I would like to see this as an opportunity for change. For example, because there's so much attention now for the digital divide, so we can use this opportunity to improve the IT or internet delivery facility. Okay, and within the field of education, I think it's also an opportunity of change for us to have come up with lots and lots of innovative ideas in both teaching and learning. And equally important, assessment. I think we really must look into more formative method of assessment rather than summative, like your one-off end of year exams or end of semester exam or SPM, STPM. things like that. And rather, we must look into the continuous development of a student. Okay, we have also seen for the past 1 year many display of selflessness and kindness among the community members. Okay, so the first step of knowing what to do is to understand and acknowledge the situation that we are in. Next, please, I would urge all of you to spread the vibe and help to educate the people around you on any information that you might have gained after today's talk. And then there are people or organizations out there who are already taking initiative to help children in needs. Take, for example, NGO like WCC or Women's Center for Change based in Penang are involved heavily in domestic violence and child sexual abuse. Kita Connect is an initiative started by UNICEF using Telegram as a platform. It is targeted mainly for adolescents. Buddy Bear is another new initiative by the NGO Humankind with a hotline available in Bahasa, English, Mandarin, and Tamil. And lastly, Thailand Kasih or 15999 is a 24-hour hotline by the government who have actually existed for many years. Now, we have discussed in the past 15 minutes or so what we have discussed in the past 15 minutes or so were merely touching the surface. Now, this once-in-a-century pandemic will fundamentally shake the way we deal with child health and child-related problems, and we have enormous impact in the years or even generation to come. There are many, these are just some of the potential future challenges that we ought to face together with our children. So in conclusion, COVID-19 poses an unprecedented crisis in humankind. It magnifies or amplifies the inequality among the community and exposes the vulnerable groups, especially children and those living in the poverty. They are the ones that will be affected most. And it will have profound impact on physical, mental, and social well-being of a child in years to come. So I would lastly like to urge all of you, again, to be aware of the situation that we are in. Please stand as an advocate for our children, and together we can act, if not today, if not yesterday. That will be this is my last slide. I thank you very much for your attention for the past 15 to 20 minutes. Again, my name is Dr. Lee Kai-yin from the National Defence University of Malaysia. Thank you very much.
All right. Thank you, Dr. Lee, for that very informative talk. Very insightful. So I would like to open to the floor now for any questions for Dr. Lee. Any questions from the participants? You can either type in the Slido or you can unmute. Swin, they can unmute, right? And
yeah, you can. So actually, I do have a question actually for Dr. Lee.
Yeah, sure.
Hi. Can you all hear me? This is Dr. Lee here.
Yes, we can hear.
Right.
So do you think there's a real risk of an outbreak of these other communicable diseases like measles and rubella, just because a lot of vaccines have been missed for this year?
Okay, right. Well, even before the pandemic, we have seen pockets of outbreaks, especially for measles and pertussis, okay, in various parts of the community. I have a feeling that the pandemic will only make this sort of outbreak more frequent going forward. But bear in mind that the chart that I showed in the presentation was the direct impact of the first nationwide lockdown. From the information that I know of late, the vaccination overall immunization rate or among the children has picked up thereafter. I think that was because it was the first nationwide lockdown. A lot of people are unsure whether they are safe to go out. So in the subsequent months, I was told that the immunization rate has gone up. But it's still not at the rate of the just compared to pre-COVID time. Yes. So the short answer is yes, there might be, but I think that a lot more the discussion need to be a bit more nuanced. The infection is spread because people are going out, mingling in schools and all that. The fact that the schools is still closed down by and large, and I mean, we are going to open soon, also means that any communicable diseases in terms of the spread of these diseases will be limited. So really, we have to see which one play a major, more important role here, whether the drop in vaccination or the drop in the social activities.
That's true. But
Yeah.
schools are reopening, isn't it? That's also the fear. So the students haven't received their vaccines for all the other diseases.
Yes.
Yeah.
Okay.
Yeah. Thanks, Dr. Lee. There's some questions in the Slido, so I'll just read out. So one of the questions is the figure of 1 in 10 Malaysian children being abused seems very high. How does that compare to worldwide figures? And what does that say about us as a society?
Okay, so this 1 in 10 refers to all sorts of abuses. We are talking about physical, sexual, emotional, as well as even neglect. So this figure is when we compare to the other worldwide figures, we are not alone, certainly. Yeah? And well, what does it say about our society? This sort of the child abuse has been there for ages. It's not something new. And as I said, it's not something isolated in our country. Okay, so I think the what is lacking is the awareness. Okay, the fact that the person who raised these questions, meaning he or she might not have known the prevalence of child abuse. So I think the awareness, therefore, I would say that we need to be improved. Okay, so this is a very real, very present problem, okay, in our society and even in throughout the world. The second thing that I want to bring up is that this 1 in 10, actually, we will still think that this is underreporting, okay, because as what we have captured really is only representing the tips of the iceberg, okay? So, yeah.
I think there was a follow-up question about availability of pediatric psychiatrists and psychologists, and are these accessible in most of the states? Yeah.
Okay. As of now, from what I know, okay, even for mental health services or professional services as a whole, we are very much still lagging behind with our peers, certainly with the developed countries, let alone the pediatric or the child services that is more dedicated to children. So I would say that this is something that we, again, after this pandemic, we have to pay attention to the development of such services. But as of now, we are talking about professional services, absolutely that's not enough. However, I think to bridge the gap while we are waiting for the services to be available, I think there are a lot of initiatives, a lot of efforts within the community. That means they may not be the professional, but they are community members, volunteers who have received some form of training, who can provide some form of mental health relief to our children.
All right. So I think due to the interest of time, we will like to thank Dr. Lee for your time and for the really informative talk just now.
Thank you very much.
Thank you, Dr. Lee. Now I would like to introduce the hang on, this is the oral presenter number 1. So we will now move on to our first oral presenter for this afternoon. I would like to welcome Ms. Jin Yigun, a student from the School of Pharmacy, Taylor's University, Malaysia, to tell us about her research on chronic wound management. And Dr. Lee and I will be the judges for this presentation. So Jin Yi, please, you can start anytime.
A very good morning to the honorable judges and the fellow participants. My name is Ivy. Today I'll be presenting the study that I've conducted it as my final year project under the guidance of Dr. Chloe with the title of Formulation and Characterization of Alginate Hydrocolloid Film Dressing loaded with gallic acid for potential wound healing. Let's start off with the brief literature review. The dramatic growth of the prevalence of diabetic foot ulcer is expected in the near future as the population ages and as the amount of cases of diabetes increases. For individuals that suffer from chronic diabetic wound, the cost of wound care is at great expenses. Having diabetes appears to significantly increase the risk of lower extremity amputation attributed to the infected and impaired foot ulcers healing. It has negatively affected patients' quality of life, escalate the danger of early death, whilst also causing significant impact on the socio-economic. Therefore, wound care is a crucial component in management of diabetic foot ulcer. However, the downside of the traditional wound dressing was that it failed to create a moist environment for wound healing and it requires routine changing to prevent skin maceration. As a consequence, it has been substantially replaced by modern wound dressing such as the hydrocolloid film dressing. Hydrocolloid film is a thin, simple and semi-permeable film. Upon in contact with the wound exudate, this matrix converts to a gel sheet to create a moist surrounding to facilitate wound healing. It is also capable of rehydrating the dry necrotic scars and encourage autolytic debridement of necrotic tissues. It has the advantage of application on flexible joint areas owing to its pliable property. Next, I'll be talking about the role of sodium alginate and pectin in wound healing. Alginate is a natural polymer, possesses good film fabrication properties due to its biocompatible and biodegradable characteristics. It is widely used as a controlled release medium in drug delivery with regards to its ability to reduce its swelling in the solvent, subjecting to the degree of its cross-linkage. This has resulted in the decreasing in solute permeability and consequently, the mobilization of loaded drugs in alginate porous matrices will be postponed. Pacting is a linear polysaccharide extracted from citrus peels. Several advantages has been discovered in it, namely its hydrophilicity, which facilitates exudate removal, its role as binding agent when added to wound to safeguard the growth factors from degradation, hence promote new cell generation, and its ability to retain an acidic environment of the wound to prevent any microbial growth. Given their excellent safety profile and comparative affordability, there has been a gradually increasing interest in using bioactive plant extracts for wound recovery. One such plant extract is gallic acid, which is a natural phenolic compound found in a wide array of plants. It is chemically known as 3,4,5-trihydroxybenzoic acid, and it is a potential antioxidant. The beneficial role of gallic acid in wound repair has been well demonstrated in a field literature review. It has proven experimentally that gallic acid is efficacious in reducing wound area and inflammatory cell infiltration, accelerating cell reepithelialization, new blood cell formation, and deposition of collagen protein, hence promoting diabetic wound healing. However, a research gap has been identified. Recently, the wound healing properties of gallic acid has been well demonstrated experimentally in both in vivo and in vitro models. However, there is a lack of research which focuses on formulating gallic acid into a stable and functional hydrocolloid film dressing. Thus, this present study will focus on the formulation of gallic acid into a stable alginate hydrocolloid film and characterize the compatibility between gallic acid and the film dressing polymer for potential low to medium suppurating chronic wound healing. The research questions for this project are: what are the effective concentrations of polymers and gallic acid in formulation of a stable hydrocolloid film dressing for low to medium exudative chronic wound? What are the characterization methods to evaluate the stability and compatibility of the formulation of alginate hydrocolloid film dressing loaded with gallic acid? What are the wound dressing physical-chemical characteristics required to demonstrate satisfactory wound healing properties? Therefore, in order to solve all the research questions, here comes to the aim of conducting this project, which is the development and physical chemical characterization of a stable alginate hydrocolloid foam dressing loaded with gallic acid for potential low to medium exudative chronic wound healing application. The objectives are to develop a stable formulation of gallic acid into alginate-based hydrocolloid foam dressing for chronic wound healing, to evaluate the physical chemical characteristics of hydrocolloid foam dressing loaded with gallic acid, to characterize the compatibility between gallic acid and the foam dressing polymer for low to medium suppurating chronic wound healing, to evaluate its potential to absorb low to medium exudate from chronic wound. Moving on, let me introduce the methodology of my project. In brief, my project are divided into 3 portions. Firstly, formulation of blank hydrocolloid foams from various combinations of polymers. Secondly, selection of the most satisfactory foam and load it with the drug gallic acid. The solvent casting method are employed in both of the formulation steps. And next, perform characterizations on the foams formulated. In the first step, which is the pre-formulation studies, different combinations of polymers powders were dissolved in distilled water to produce a gel. The gel was then homogenized with constant stirring and heating. It was then placed in a sonicator to eliminate the trapped air bubbles. After that, the gel was poured into the petri dish using the film casting technique. Finally, it was left to dry in oven and stored in desiccator until further use. These are all the drug-free hydrocolloid foams formulated using a polymer ratio of 1:1. The polymers used in my experiment includes sodium alginate, Pacting, sodium carboxymethyl cellulose, chitosan, and fluoronic F127. Moving on to the next part of the project, which is formulating the drug-loaded foam. After the preliminary assessment, SAPC hydrocolloid foam was found to be the most satisfactory composite foams with smooth surface, no bubbles, homogeneous and pliable foam texture. It was selected for further incorporation with gallic acid to produce the drug-loaded foams. Gallic acid concentration of 0.1%, 0.5% and 1% weight by volume was determined based on the existing literature review and formulation suitability. SAPC blank hydrocolloid foam were used to act as a control throughout the experiment. After all the drug-loaded foams were formulated, they were then proceed to the third part of the project, which was characterize the foam based on their physical properties. The first characterization parameter will be the physical assessment and microscopic analysis on the foams produced. From the pre-formulation studies, SAPC foams were identified as the most satisfactory foam and was selected for further loading with the drug gallic acid. All the gallic acid loaded foams has demonstrated a dark brown color due to the drug and has exhibited a smooth and flexible texture equivalent to the blank SAPC foam. When viewed under the microscope, all the foams show a homogeneous and smooth surface without any visible bumps, defects, or cracks, hence indicating the excellent compatibility between the drug and the SAPC polymers. These are some of the foams formulated from the pre-formulation studies that were rejected as they shown to consist of air bubbles with rough and bumpy surfaces. Some of them have also displayed characteristics of non-homogeneously mixing and cracking appearance on physical examination. Moving on, dressing that could lower the pH of the wound exudate has the potential to halt bacterial infection and create a more conducive environment for wound recovery. This is because the replication of most of the pathogenic bacteria are restricted by a lower pH value. All the polymeric gels formulated using the Pacting polymer display a slightly lower pH value range than the other combination of polymers which are having a slightly higher pH value range. This is one of the reasons of SAPC foam being chosen to load with the drug. All the gallic acid loaded foam formulated has also exhibited acidic properties with a pH value range of 3.97 to 4.04. Research shown that film with a higher viscosity value are beneficial in residing on the wound site for a longer period of time. Moreover, the ability of the film to retain the viscous properties without drastic change after the absorption of wound exudate is crucial for the drug release profile as well. SAPC film with moderately high viscosity value of 1974 mPa/s has been selected among all the other combinations of polymers. All the gallic acid loaded films display a fairly high viscosity, and the viscosity increases as the concentration of drug incorporated increases. From the FTIR analysis, FTIR spectra of all the SAPC gallic acid film exhibited characteristic peaks of individual polymers of SA and PC, as well as the drug gallic acid. The FTIR spectra of all the drug-loaded film did not display any major distinction from the blank film, and no new characteristic absorption bands was noted. This indicates the lack of obvious chemical reaction between the drug and the polymer, which proves the homogeneity mixture between them. A good drug matrix compatibility also signifying that the therapeutic efficacy of the drug is retained. MVTR, moisture vapor transmission rate, was utilized to measure the gesture exchange through the wound dressing on wound. A functional wound dressing should provide an moisture vapor transmission rate that inhibits the accumulation of exudates or excessive loss of moisture from the wound bed to create a moist healing environment to advance wound recovery. An optimal MVTR is extremely crucial, as a significantly high value of MVTR may cause dehydration at the wound site, whereas an inadequately low value of MVTR may lead to the accumulation of wound fluid. MVTR of all the formulated films were reported to fit within the range for injured skin, and all the gallic acid loaded films are able to maintain sufficiently high humidity for wound healing. From the moisture absorption studies, we realized that all the films formulated have the capability to absorb water molecules from the humid environment, and the result has also suggested that the gallic acid loaded films with a lower percentage of moisture absorption is more favorable for low to medium exudative wounds. Last but not least, swelling studies was conducted to assess the swelling rate of film dressings under the exudative wound condition, and gelatin gel was employed as a simulated wound fluid model to mimic the conditions of the separating wounds. The 0.1% gallic acid loaded SAPC film presented with the highest expansion rate in the first 4 hours, slower in the 0.5% weight by volume, and followed by the 1% weight by volume film. All the films attained a nearly plateau state after 8 hours, where they became highly viscous and could not expand further. Wound dressing that retain its integrity for a prolonged period of application is desirable for exudative wounds and will ease the removal of dressing, attributed to the convenience of withdrawing the dressing in a single piece. Therefore, from the experiment, we can deduce that the 0.1 weight by volume film is more suitable for low suppurating wounds or for shorter term application, and on the other hand, the 1% weight by volume film may be useful in medium to heavy exudative wounds or for longer term application owing to its high water retention capacity. Adequate swelling is also a critical property for uniform and prolonged drug release. Lastly, as a conclusion, in this present study, film dressing based on alginate pacting incorporated with 0.1%, 0.5%, and 1% weight by volume of gallic acid were successfully developed by using the solvent casting method. Macroscopic and microscopic analysis revealed that all the films formulated were smooth, homogeneous, translucent, and flexible. The film also exhibited ideal wound dressing properties of acidic pH, moderate viscosity, optimal MVTR, slower moisture absorption, and film expansion rate, thus suggesting its potential use as a wound dressing for low to medium suppurating wounds. In addition to that, an excellent homogeneity and lack of chemical interaction between the polymers and the loaded drug revealed by FTIR analysis further supports its potential efficacy in wound healing. Last but not least, future investigations which focuses on the in vivo performance of gallic acid-loaded film formulations are highly needed to establish its safety and efficacy profile as a chronic wound healing agent. At the end, I would like to take this opportunity to point out the limitation and challenge faced while I was conducting this study. I was quite disappointed as I actually failed the in vitro drug release study using the Franz diffusion cell at the first attempt. I remember it took place at the day before the implementation of CMCO, and due to the lockdown to break the COVID-19 change, I couldn't manage to go back to my campus to repeat the experiment to get the result. Despite the flaw, all in all, I'm beyond thankful to have completed this study with the support and guidance from my supervisor, the laboratory staff, and my lab mates. That is all about my study. Thank you so much for listening to my presentation.
All right. Thank you, Jingy, for that very interesting presentation. We will now take some questions from Dr. Lee and the audience.
All right, shall I begin?
Yes, Dr. Lee.
Okay, right. Thank you, Ching Yi. So yeah, I applaud you for the effort to complete the study, even with the restriction of movement and so on. First off, I think I need to disclaim that I'm no expert in biochemistry or pharmacology. These are rather technical studies. But I do have two questions that I would like to direct to the presenters, any of the or anyone in the team member. The first one is that, is this the first of a kind study to combine the three components that we mentioned, namely alginate, pectin, and gallic acid as a wound dressing agent? So is there any other identical study in other parts of the world? The second one is that, what sort of objective definition do the researcher use in defining low or medium exudative wound? Is there any objective definition for that? Okay, and how do you duplicate this sort of similar property experimentally in the lab? Thank you.
Okay, thank you for the question. So for your first question, yes, this is the first study that incorporating the three components, which are the gallic acid, sodium alginate, and pectin, whereas there have been study just using, they incorporate another active pharmaceutical agent into sodium and alginate. So this time around, I was actually using another type of drug. Yeah. Then for your second question, low to medium suppurating wound, how to define, right? I guess thank you so much for the question. It is a very good question, but unfortunately, it falls outside of the scope of my research. So I'll be looking more into this area later on. Yeah.
Okay, we have some questions as well from the audience. So the first one is this suitable for other types of skin ulcers like pressure ulcer or sores?
Yes, yeah, it is. But then I would say more future work is needed to investigate about this.
Okay, and then have there been any previous head-to-head comparison studies, either in vivo or in vitro, between the plain hydrocolloid film dressing and the one that contains the gallic acid? Have there been any previous comparison studies?
Yes, it is. There has been a few studies demonstrating the and containing gallic acid. Yes, but then they are not using hydrocolloid film. Yeah, but then they successfully demonstrate the clinical activity of gallic acid in reducing the like, for example, the size of the wound, advancing the tissue migration for better wound recovery. Yes, it is.
Right, and then has gallic acid been tested in vivo in humans?
From my research, I think I have encountered the use of gallic acid in human. Yes, but then I do not really look into it as my study is focusing on the uh, transdermal pad on skin.
Oh, okay. Any reports about the safety or any toxicity issues with gallic acid?
So far there's no that I've encountered.
Okay, and what about any antimicrobial activity being reported for gallic acid?
No, not really.
Okay, all right. Another question is with regards to the risk of allergic reaction to either the hydrocolloid film or the gallic acid. Is there any risk of allergic reaction if you apply this in humans? Any allergic reaction that you can
I
have?
guess if I'm not wrong, I guess the allergic reaction has to be tested in vivo, for example, like in animals.
I
Yeah.
see. Okay. I do have a question as well. I am not an expert as well in the diabetes, especially diabetic wound, but I did have a relative who was suffering from diabetes and had very severe diabetic wound. And the doctor, as well as the physiotherapist, advised that she should keep the wound area dry to speed up healing. But from your presentation just now, you mentioned that the moisture, keep maintaining the moisture is ideal for the wound healing. So can you explain a little bit more? Why is maintaining a moisture level ideal or optimum for the healing process?
Okay, thank you so much for your question. I would say adequate moisture is needed because it actually provides capability to permit adequate exchange of gases with the environment, and then it enhances the migration of the epidermal cell, as well as advance the angiogenesis and then increase the synthesis of connective tissue. If the environment is too dry, right, couldn't achieve this. Yeah, I would say in a slower speed. Yeah.
Okay, maybe I'm not too sure, but maybe you had to also look into specifically for diabetic patients whether this one is applicable as well, or is it wound moisture content in wound healing is more applicable for healthy or normal people without diabetes, because seems like in practice the dryness of the wound sort of heals the diabetic foot ulcer faster, it seems, and lead to less risk of amputation. So I'm not too sure. I am not expert as well in this, but maybe it's something to look into.
Okay.
Yeah.
All right. Thank you for your feedback.
Any other questions from the floor or from Dr. Lim as well, from Suin?
Oh, I'm afraid I'm not a pharmacologist or biochemist either. But then just thinking, so your experiment involved mimicking a suppurative wound condition, right? So an exudative wound, a wound that produces a lot of pus and water, that sort of thing, isn't it? Does that actually improve the efficacy of your gel? I mean, why do you choose that sort of wound situation? I can't understand why specifically, because some wounds are dry and some wounds are very exudative. Any reason for, is there a, you demonstrated, is it actually a more effective film on a suppurative wound compared to a dry wound? Does the exudative aspect of the wound actually improve the function of the gel? Is that something important? Or actually the opposite, it in fact impairs the function of the gel film? I just want to know what's the ideal situation for gel film to work. Because we got different.
Yeah, go ahead.
Oh no, just explain, because we do have different gradings of diabetic wounds as well, and the sort of lower grades, contact skin, and then when they get infected or deeper, they can be quite exudative.
Because my study was actually focusing on using hydrocolloid film dressing to develop the wound dressing, right, using hydrocolloid. Yeah, so actually I will be mainly focusing on how I can develop this hydrocolloid and what are the properties of this hydrocolloid so great in for wound dressing. Yeah, so it's actually it has high absorption capability via its strong hydrophilic gel formation. Then besides that, it is a very thin, simple, and semi-permeable film. So it is good for examination of the wound condition as well as effective oxygen and vapor transmission, which is good for wound healing. Yeah. Then besides that, upon in contact with the wound exudate, right? So this matrix will convert into a gel sheet from a very dry dressing. Then this will actually create a moist environment for the wound area to facilitate the proliferation of skin cell, which is beneficial in wound recovery, hence reduce the formation of scars.
Okay.
Can I ask a question?
Yes, Dr. Vivian.
Hi, Ivy. Yeah. So you mentioned a while ago that your main purpose is actually to formulate, it's like a drug delivery system, right? So the hydrocolloid film dressing. And you said that it's the first of its kind. Were you able to compare it with what is already in the market as a drug delivery system for other wound healing for ulcers?
If compared to the traditional wound dressing, so as we all know, chronic wound normally associated with enormous wound exudate, and hence managing the exudate is very important in order to guarantee wound healing. Yeah, so if compared with the traditional wound dressing, it requires routine changing to prevent it from moistening with excessive the wound fluid, and hence are more likely to adhere to the wound area, and hence making the skin macerating and painful while removing the dressing. So therefore, we have this hydrocolloid film, which allow the permeability of gas and vapor. So that's why that's not that dry. Then when it's being removed, it will not be so painful as well. Yeah.
Okay, thank you.
All right. Thank you so much, Jin Yi, for your very interesting presentation and also for the Q&A session. So I would like to now introduce oral presenter number 2, Mr. Chu Song-yong, a student from the School of Medicine, Taylor's University, to tell us about the outcome of their EBAC program that was implemented for medical students. Dr. Lee and Dr. Verbo will be judging this presentation. So welcome, Song-yong. The floor is yours.
Good day, everybody. My name is Chu Song Yong, and you can address me as Ivan. I'm a medical student from Taylor's University, Malaysia. And today my research topic, my presentation is on EBUG. And the title is written here, Effectiveness of EBUG, an assessment of students' knowledge on respiratory hygiene via EBUG program. So before going on to my presentation, just a brief introduction on what is EBUG. Some of you may have heard about it, some of you may not. So EBUG is actually developed in England, and it is an educational resource for children, for students to study on microorganisms. So actually, EBUG has its own website, and inside the website you can find various topics like respiratory hygiene, which I'm going to talk about today. Other topics are like farm hygiene, food hygiene, oral hygiene, or hand hygiene, etc. Okay, moving on. This is what my presentation will include: the introduction, literature review, methodology, results, conclusion, and recommendations. Okay, going to the introduction, it is just because my topic is on respiratory hygiene, so talking about briefly on the global prevalence. Acute LRT, which is lower respiratory tract infections, have been among the top 3 causes of death and disability among both children and also adults for decades. It is also estimated that LRT causes nearly 4 million deaths annually, and it is also a leading cause of death among children under 5 years old. And it is important to talk about COVID here because my topic is on respiratory hygiene. And these are the data taken on 18th of February, which is the date which I'm presenting now. So currently, COVID-19 has infected over 110 million individuals worldwide, resulting in over 2.43 million deaths. In Malaysia, there are over 272k cases, resulting in 1,005 deaths as on 18th of February, which is today and now. So, okay, the problem statement and objective of my study. So again, as I've mentioned just now, EBUG is a free educational resources to learn about microorganisms developed by England, and it is currently used widely in England and Scotland, and it is linked to their national curriculum. But then in Malaysia, its effectiveness is not proven yet because there are inadequate studies conducted. So my study is conducted to determine if EBUG is a suitable and effective platform for children to increase their knowledge, and I use respiratory hygiene. So whether they can increase their knowledge on respiratory hygiene using EBUG. And it is also to act as a pilot study towards the inclusion of EBUG program in curriculum of Malaysia, and also provide children with the knowledge on respiratory hygiene. So basically is to see whether using EBUG to teach them respiratory hygiene is effective in increasing their knowledge on respiratory hygiene. Okay, some literature here. I have taken 1, 2, and 3 studies. Actually, there are more, but in this presentation, I'm going to talk about these 3. Okay, the first study is taken from Charlotte Victoria Ely et al. The key findings is that educators value the EBUG resources as useful resource. So I'm going to highlight some of the differences here. Their targeted groups are educators, as highlighted here, instead of school children, which are used by me. I use school children instead of educators. Later in methodology, you'll see why. And the second study here, also to study the effectiveness of EBUG. So you can see here, evaluation showed that students' knowledge improved significantly. However, one of the difference is that they separated their study group, which are school children, similar to my study school children. But difference is they separated the school children into different age group, which is not my case. I've grouped them all together because the population is not enough. Okay, the next one. And the last study here, the key findings is also that the EBUG resource pack is effective because, as highlighted here, significant improvement in junior EBUG teaching. In senior schools, the studies stated that the students' knowledge improvement varied. Similarities is the aim, as like what I said, to determine the effectiveness of EBUG. And the differences is they use 3 intervals, whereas in my study I use 2. Their intervals are baseline, post-intervention, and retention. In my study, I only have baseline and post-intervention. Also, the study groups, the children, they are divided into different age groups. Okay, going to the methodology. In my study, two main populations of school-going children were used. The first one is PPR, Program Perumahan Rakyat, PPR Sri Pantai residents. And another one is the children who are from random schools in Klang Valley. And okay, so after I gather all the children and their phone number, parents' phone number, the quiz on respiratory hygiene was delivered to them via a Google form link through their parents' WhatsApp phone number. So in this Google form, there are two parts, which is not, I didn't write here because it's quite long. So two parts. First part is to take their details like name, WhatsApp number, address, age, gender. And the second part is the quiz on respiratory hygiene. And this quiz was adopted from the EBAC website. So, and just to mention here, in the Google form, their addresses were recorded because after that we tell them we will deliver them some grocery items. So maybe this will motivate their responses. Since we cannot go there because of MCO, because of COVID-19 restrictions, so we use the WhatsApp number. And the students were required to do the quiz before watching the video prepared by me, and the video later I'll show you also. So there's a video. So they are required to do the quiz before watching the video and after the video. So inside the quiz, a total of 8 points can be scored. So the points, obviously the points scored before and after will be compared and analyzed using SPSS. Okay, this is the video. Let's watch it. It's just 2 minutes.
Many diseases are airborne and can be spread through droplets of water or aerosols, through coughing and sneezing. Aerosols in sneeze can travel at over 100 km per hour, covering a distance of over 4 meters, which could spread microbes to a lot of people. So these are the droplets of aerosols containing microbes, covering a wide part of areas. It is best to prevent spread of aerosols which contain microbes to other people by covering our mouth when we sneeze or cough. The best way to cover our nose and mouth is through a tissue paper, which will trap the microbes and then dispose it to the bin, and after that wash our hands. If we cannot find a tissue paper nearby, the next best way to cover our mouth is with our sleeve. Although by covering our mouth by hands can prevent spread of microbes, the microbes can stay on our hands, which allow us to spread the microbes by touching. Hence, it is important to wash our hands carefully. A quick recap. We can spread microbes to others by touching, sneezing, and coughing. The best way to prevent spread of microbes is by covering our mouth with a tissue paper when we sneeze or cough, and then dispose the tissue paper into the bin. If there is no tissue paper, cover our mouth with our sleeves. Try to avoid covering mouth with hands as microbes can stay on hands, and always wash our hands after we sneeze or cough.
COVID-19 adalah satu penyakit yang disebar melalui titisan nafas yang dikeluarkan bila kita batuk, bersin atau dari menyentuh orang dengan tangan kita yang telah dijangkiti dengan virus. Untuk mengelakkan kesebaran COVID-19, kerap basuh tangan dengan sabun, air dan gel antiseptik. Pakai pelitup muka bila di luar rumah. Lebih baik untuk menukar pelitup muka setiap hari atau membasuhi jika pelitup muka dibuat dari kain fabrik. Jaga jarak dengan orang lain. Jangan sentuh mata, mulut dan hidung dengan tangan kotor. Dan berduduk di rumah jika anda rasa kurang sihat.
Okay, so that is the video. And the questionnaire is delivered again to them using a Google form link. So this is the first part I've talked to you about, and the second part is the quiz. Okay, this is the quiz part. So this quiz, the questions are taken from the EBAC website, okay? So they are like, these are the correct answers, 1, 2, 3, 4, 5, 6, 7, 8. So a total of 8 points maximum can be scored by the children. Results and discussion. So a total of 24 children of PPR Sri Pantai completed the quiz before and after video intervention. Before that, we have 30 children 30 children with their WhatsApp phone numbers, but only 24 of them completed the quiz. The mean score after watching the video is more than the mean score before watching the video. And we used paired sample t-test to analyze the data, and the p-value was less than 0.05. Hence, there is a significant difference statistically. And these are the statistics here. The mean scores are written here. You can see before, after the video is higher than before the video. This is where the p-value is less than 0.05. Then about the random schools I've talked about just now, there are only 13 children who took part in the quiz, who completed the Google form before and after video intervention. The mean score is also higher after the video intervention, and the p-value was also less than 0.05. Hence, there is a significant difference statistically. So the mean scores are, you can see here, p-value less than 0.05. So to conclude, from this study, the scores before and after watching the video, the participants from these two populations have shown significant improvement on their knowledge on respiratory hygiene taught by EBUG. And this pilot study has demonstrated the success of and effectiveness of EBUG as an educational resource on respiratory hygiene for children in these two populations. So a brief on the recommendation. Some recommendations are: Ministry of Education could increase the emphasis and awareness of respiratory hygiene teachings by implementing the EBUG in their school curriculum, or schools can organize competitions using resource from EBUG. Example like best presentations on respiratory hygiene or best videos created on respiratory hygiene. Besides from school level, other settings like clinics, hospitals, educational fairs can also implement the content from EBUG in order to increase the awareness of respiratory hygiene among public. And that's all. Thank you very much, everybody.
All right, thank you, Song Yong, for the very clear and fascinating presentation. I would like to now invite Dr. Lee as well as Dr. Vivian to present your questions to Song Yong. Yep, thank you.
Dr. Vivian, would you like to start first?
It's okay, you can start. Thank you,
All right.
Dr. Lee.
Okay, thank you. Okay, thank you, Sing Yong, for your presentation. Before I ask my questions, I would like to clarify a few key information. Number one is that when was the study period? And secondly, what was the language used in the questionnaire? Can I have the information first?
Okay, yeah, sorry, I forgot to clarify in the slides. So the study was done during this month, mid-February. So it was only like 2 weeks for us to do the study. And then the language used was mainly, the language of the quiz was translated into BM. And then my video, I used English and subtitle was Malay.
So the questionnaire was in Bahasa?
Yes, Bahasa.
All right, okay. So I have 3 questions for the presenter. Number one is that what was the randomization? What was the method of randomization for the children from PPR? And you mentioned also a random school, right? And what was the method of randomization? That's number one. The second question for me is regarding the questionnaire the answer given in the questionnaire. How do you ensure that the forms are filled by the children themselves and not assisted by the family members? And number 3, I think you did not present what are the limitations of the study. Okay.
Okay, the first question, I believe our sampling method was convenient sampling, because there were one lady, Puan Salma, who just gave us the numbers and we just took from what existing participants were there. Then for the second question, how do we ensure that the students are doing on themselves, right? Actually, I would like to say sorry, because this is one of the limitations also, because we were supposed to go to the area, because around end of January and beginning of February, I forgot the time, the government announced the extension of MCO, right? So before that, we thought we could go to the place, but then when the government announced, we have to come up with a like immediate plan B. Then we resort to taking their WhatsApp number. So actually, we can't make sure that the children do that themselves. Yeah, we were hoping we could go there so that we can monitor the children doing that and then like show them the videos. So the third one limitation is this one. We can't confirm whether the students do that themselves or the parents like help them. Second one is about the time. I mentioned just now, we were given only, in this posting, we were given only 2 to 3 weeks to do that. So participants were not enough, and then preparation, I believe, is not that adequate also. So we were difficult to come up with like good research. But then we tried to get as much as participants lah. And then we have like 5 days of data collection period. And then during these 5 days, the lady who gave us the phone numbers are like coming in during like even the last day also the phone numbers came in. So if time length was longer, so maybe the participants, the population field is like larger. And then some parents also, no, some students also like took 2 to 3 days to complete the quiz before and after video intervention. So time is a major problem here. And then that's why the participants number were also a problem.
Okay.
Thank you, Doctor, for the questions. What is the time? Oh, should I answer the slide?
Yes, we have some questions, yeah, Song Yang, in the Slido. So what is the time frame between the first quiz and the second quiz?
Yeah, between the first quiz and second quiz, we didn't actually set a time frame. So we give the first quiz to the parents and then ask them to let their students to, because we send that to them, and then we know like they are working and then they have their own things to do. The students have to go to school, so we understand that. So we didn't actually set a time. So first quiz we send to them, and if some parents don't reply by by the second last day of our data collection, then we will send another message to them to remind them to to watch the videos. Then after that, only they reply us, and then only we can send. They do the first quiz. Then after that, they notify us. Only we send the second, send the video, and then ask them to do the second quiz.
Okay. Were all the students in the study from similar social and educational backgrounds?
For PPR Seri Pantai Project Perumahan Rakyat, I think the social and educational background should be the same. They are classified under B40 income population. For random another group of population, and then also the age group is 9 to 12 years old. And yeah.
Okay, all right. Before I ask the one more question at the Slido, Dr. Vivian, do you have any questions for
Yeah.
Song Yong? Yeah.
So similar to what Dr. Lee asked, because regarding the questionnaire, right? So were the parents given proper instructions on how to administer the questionnaire to the student? Were there proper instructions for that?
Yes, we have like generated a message on BM because most of them are the race is Malay. So we like type out a message like, thank you for participating in our research. And then we told them first you do the quiz. After that you notify us, like maybe say done or sudah siap. And then we will send them the second quiz, and then we will send them the Google form link again so that they can like easy access to the Google form and do the second time. And then we also instructed them to select particularly like in the first question, like before, or you are doing this before or after the watching the video. So I believe the instructions were clear to them.
Okay, and my next question is, because your recommendation is to use the e-bug, right, for the schools, is there a plan for you to do like a Malaysian version instead of using the resources from UK?
Okay, so because ebug is a ebug, like the ebug resource is found in the ebug website, and then the main language is English, and then it is used widely in England and the European countries. And my friend actually do the language in Oman language. So actually we were just required to translate it exactly the same, use their content, use their resource pack, and translate it to our own language, so that like we can prove that the resource pack is useful. So if it is really useful in the future, the plan is just to translate the same thing, the exact same thing from English to Malay, and then under ebug there is a section for like under Malaysia, so that we can put under Malaysia all the language in Malay, but then the content is exactly the same as the main English.
Okay, thank you.
Thank you.
If I may,
Yes.
may I know for the purpose of this study, who did the translation?
Oh, because sorry, my VM is not quite good, so I get some help from some one friend who is Malay, and then another friend like who is also good in Malay to help me. So two friends, three. And then from the video, you can also see another girl like speaking in Malay on the COVID. So they really helped me a lot for my translation to VM.
So many peers, many your peers, and rather than any professional bodies. Okay, right. Okay.
Thank you.
We have one more question in the Slido, which is the eBug resource open to members of the public?
Yes, if you type ebug website into Google, you can like easily access, and then you can choose whether you are students or you are teachers to access the resource, and then you can choose the language of your liking to suit your understanding.
So we do not have to inform the developers of the ebug the ebug content, is it?
No.
Want to do a separate study in our country, we do not have to collaborate with them or to acknowledge them, collaborate with them formally, like say for example you want to publish your study later on, you're in an article in a journal, say, do you need to acknowledge them or even to put them as a co-author, for example?
I think if I want to publish the study, I have to inform them. But then now it's just like pilot study among these two populations, so we didn't actually inform them. And then my advisor is also doing like proper research on ebug, so that like I'm just following her and helping her on the small topics like that.
I see. Okay.
And now some tools are copyrighted on there in education and biomedical sciences. So I suppose if we are going to do a study, we just have to check the small print on the website to see if the questionnaires got any copyright.
Yeah,
in that case.
true.
Thank you, doctors. Thank you very much for the questions.
All right. Thank you, Song Yong, for a very clear presentation. We've still got some time before this session ends. Any further questions for Song Yong or for Jin Yi or even for Dr. Lee? No. If not, I have a question as well for Dr. Lee. So you presented about the your presentation actually opened our eyes to the problems faced by the children if they are at home and not going to school. For example, like the domestic abuse and the psychosocial impact of them staying too long at home. But on the other hand, when we allow them back to school, there is also the fear of the risk of community transmission, and then the follow-up increase in the number of cases, because presumably children do not follow the SOP as stringently as adults would. So would you have any recommendation on any effective measures or guidelines or SOPs that for example, the governmental agencies should adopt before allowing the children back, or even when the children are back to school? Because bearing in mind that children will not be receiving the COVID-19 vaccines, right?
Right.
So yeah, I'd just like to hear your opinion, Dr. Lee.
Right. Okay. Thank you for the questions, Professor. Now, yeah, I think rightly so. Number one, children are less likely to adhere strictly to the SOP, and secondly, they are not in the vaccination group. Well, I think if you look at the data and the recent data, large study data, large population data coming from UK, what we know currently, unfortunately, is that children are indeed likely to carry the virus and to spread it to their household members up to 2 times higher than the adults, for the reasons that we have discussed earlier on.
Yep.
In other words, I think there may be a potential scenario where if the school is reopened, the spread of COVID can take place easily. The solution to that is not is very, very tough. I think as I presented earlier on, not opening school is also depriving some of the children of their lifeline, nutritionally or even socially. So definitely this is a very, very tough call from the Ministry of Education and also from the Ministry of Health. Now, some of the experts do give sort of a middle ground solution. I'm merely quoting them. Okay, so for example, if one of the way is to look at microdata, rather than putting a whole state as a red state, for example, or even the whole district as a red district, we might break down further the data into smaller packs of data, into community data, and then we decide within that community, within that particular school, for example, whether they are safe to open or not, looking at the daily infectivity rate, daily positive rates, and then based on those data, we make a decision whether it's safe to open up or not, rather than a centralized decision, rather than a one-size-fits-all approach. That sounds like a more sensible ways of doing things, but it's a lot easy said than done, obviously.
Yeah. True. Thank you for the insights and for the information there, Dr. Lee. So I would like to now pass the time to Dr. Joanne for an announcement that she's going to make. Dr. Joanne?
Hi. Good afternoon. Hi. Yeah, some ice breaking. So now we're back for the raffle draw. Dr. Sapna, can you help me out to identify a volunteer?
Yes, hello everyone. Hello, Prof. Chong. And thank you for allowing us to be here. Yeah, so we need a volunteer to pick up one lucky winner. And as you have noticed, volunteers, the winners, if they're not here on the channel, the volunteer will get lucky and get the prize. So
wow, Dr. Rajan is in the room, right? Yeah, hi, Dr. Rajan.
Hi, good afternoon, everyone.
Yeah, he's very instrumental in our sponsorship. He used to be the occupational doctor, chairman of Unilever Singapore. Am I right, Dr. Rajan? Wow. Yes. And our sponsor, major sponsor is Unilever. So we are giving Unilever products now, Prof.
Very good. Excellent.
Oh, wow.
All right. So maybe Dr. Sapna, can you choose one? Pick from our participants in the room?
I can see Mohammed Janahi. Are you here?
Hello, Doctor. Yes, I am here.
Hello. Can you please put on your video so that we
Wow,
can see?
Janahi is from Bahrain, if I'm not mistaken, right?
Yeah. Hello.
Hi, Janahi. Wow. Yeah. All right. So, Janahi, you just pick one number, random, just random, from 1 to 813. If you're
So,
here during lunch break, it's the same thing that we're going to do. All right. 1 to 813.
so 11, please.
Number?
11.
Okay, number 11. All right. Can the host allow me to share my screen so we can look through the registration list?
No?
Yeah. Can I share screen now?
Sure.
All right. Number 11, Janahi. So if this person is not in the room, then we have to give you the 100 ringgit worth of Unilever products. And Dr. Sapna, you have to convert it to cash because I cannot send it there. All right, this is Abid Zaravana Kumar from New Zealand. Is he here?
Abhijit, are you here?
She might be presenting her own oral presentation elsewhere.
All right. So anyway, so maybe we can just give it to Janahi. All right. Thank you. Congratulations, Janahi. So we'll have one committee member who would like to buy this grocery so that we can send the $25 to your account. Anyone from the floor? Anyone?
What's the grocery?
Dove, Nor, Lifebuoy.
Hey guys, you all should buy this. It's good.
Yeah, Dr. Rajan is marketing. Thank you.
All right, we'll share and buy it.
All right, thank you so much, Dr. Suyin. Dr. Suyin is one of our technical committee and she has been really working hard for the past few days. Thank you so much, Dr. Suyin. All right, we'll keep in touch with you, Janahi.
Thank you, Doctor.
All right, all the best for your presentation. All right, thank you, doctors. You have
Thank
to
you,
go. Bye-bye, doctor.
Thank you.
Bye-bye.
Bye-bye.
All right. So thank you, everyone. We'll wrap up the first session of the afternoon on primary care. I would like to thank Dr. Lee and the oral presenters, Jin Yi and Song Yong. It is clear that primary care has a very important role in public health medicine, not only in terms of preventive healthcare, but also as an important advocate for the public. I will now invite my co-chair, Dr. Vivian Verbal, to start off the next session of talks. So over to you, Dr. Verbal.
Thank you, Professor Chong. Without further ado, we will now move on to the theme of occupational safety and health. Our main speaker for this part of the session is Dr. Guharajan Nadarajan, who will give us some insight into his work on occupational health medicine. He is a physician with a wealth of experience in this field. Welcome, Dr. Rajan.
Good day, everyone. My name is Dr. Rajan. I practice medicine in the specialty field of occupational health. I have just retired as the Regional Medical and Occupational Health Advisor for a multinational manufacturing company. I've also had the opportunity to serve as an adjunct lecturer at the Occupational Health Unit, Faculty of Medicine, University, Malaya. The subject I would like to touch on today is on this concept of return to work, from absence to presence. No one plans to get injured, more so at the workplace. The effects of injury, needless to say, can result in both short-term and long-term absence from the workplace. Return to work solutions are unique, as is each injury and job. While the attending physician's responsibility is only towards the patient, the responsibility of the occupational health physician encompasses the patient, the safety and health of the other employees, and the interests of the employer for whom the employee works for. Before we go further, it is important for us to recognize a few terms that are commonly associated with this concept of return to work. Impairment. This can be defined as a reduction in normal function. Disability refers to a restriction or an inability resulting from an impairment to perform an activity in the manner within a range considered normal for a human being. And handicap refers to a disadvantage in filling a role in life relative to a peer group. Impairment should not necessarily imply that work disability is present, unless there is functional limitation that prevents the worker from performing the tasks required in their job after considering available workplace adjustments. From these pictures, you can understand that not all cases of impairment lead to disability, and not all cases of disability lead to a handicap. Work is an important part of rehabilitation. Long periods away from work can lead to issues affecting mental and physical health. Any advice to stay off work, be it short-term or long-term, must consider the effects of such a decision both for the individual and for the workplace. It is possible, with employer support, for appropriate work adjustments to be put in place to manage common health problems at work. Workplace disability management must include a plan not only to support a return to work, but also staying at work. The whole purpose of a return to work examination is to ensure that an individual is fit to perform the task assigned without risk to one's own or to others' health and safety. No two injuries are the same, and hence return to work programs pose a tremendous challenge to the occupational health practitioner. Medical fitness does not solely rely on the medical condition, but on any resulting impairment or disability. Return to work programs are only as good as the people who are involved in it. Return to work programs involve three major stakeholders: the employer, the occupational physician, and the employee. There are certain factors that affect a successful return to work program: the nature of injury, the degree of impairment or disability arising from the injury, the place of injury, the treatment obtained, accessibility to treatment, the job demands at work, the attitude of the employee, the employee's compliance and response to treatment, and the workplace environment. Is the environment capable of affording workplace accommodations that not only facilitate a return to work, but also ensure that an individual can stay on at work once returned. This is an X-ray of the spine, lumbosacral region. This individual was working in a job that involved highly repetitive tasks, awkward postures, high intensity work, long hours of working. And in this X-ray, you will be able to see that there is a narrowed disk space at the L5-S1 level. This is an MRI of the same individual, an MRI of the spine. And if you follow the red arrow, you would be able to see that there is a generalized protrusion of the disc at that level onto the spinal cord. There's also some mild protrusion at one level higher, if you can see that clearly. This is a pain phases scale that we can use to understand the degree of discomfort an individual is going through. Pain is very subjective, and having this sort of scale gives us an idea on how much pain an individual is suffering from. In this case, the scale is at the indication is at the maximum. There was initial medical management for this patient, medication, time away from work, physiotherapy, but as there was not any sufficient progress, the attending doctor felt that more invasive treatment was required, and the employee underwent a posterior decompression, fusion, and stabilization. This is the workplace management program that was specifically drawn up for this individual. As you can see, the initial months focused on physiotherapy and rehabilitation, and then slowly he was brought back into work, retraining, a gradual increase in duration and intensity, managing his working hours. So that is the reason we said no overtime for a couple of months until the back muscles were sort of strengthened, his pain was minimal. And then, as you can see, he was discharged from orthopedic follow-up after 6 months, yes, and he went back to his full duties. Yes, this is the pain phases scale of the individual post-surgery, post-therapy, and as you can see, the indicators have come right down. This is also very valuable in helping us manage his return to work in terms of the pace of work, the intensity of work. So, what is the role of the occupational physician then in such return to work programs? The first thing would be communication. And when it comes to communication, it's very important never to forget medical data is always confidential. You are dealing with various stakeholders. Some may be medical, some may be non-medical personnel. The degree of information that you can share with each of them, how you communicate to each of them is very, very important. Your role to classify the injury as an impairment or a disability. For once you classify an injury as a disability, you're then looking at workstation evaluations, functional capacity evaluations that can be done through questionnaires, objective measurements, and finally goal setting. Goal setting needs to be collaborative among all stakeholders. Health professionals are prone to frame goals in terms of physical outcomes, while employers are prone to frame goals in terms of man hours away from work. Goal setting needs acceptance from both employee and the employer. It needs to be dynamic. It needs to take into consideration factors such as the type of work environment, work skill required, availability of modified work, and the employee's attitude. When does it end? It really never ends for an occupational physician at the workplace. It is not only an individual returning to work, but staying on at work. And this aspect of staying on at work needs time, needs follow-up, needs consideration, needs communication. And therefore, I would always say your role as an occupational physician is never ending. Any discussion on return to work must include an element of prevention. Preventive-based programs at the workplace do help reduce health-related work disability. It has been shown that good physical and mental health, positive health behaviors, absence of chronic disease are all associated with low occupational and general injury rates, thereby leading to decreased health-related work disability. Healthy workplace programs, health screening, appropriate training, disease management, workable return to work programs that limit the impact of disability are all strategies that can be applied to help decrease health-related work disability. In conclusion, an early and successful return to work program involves having a positive relationship between all stakeholders, as sharing problems and solutions gives the best results. The challenge faced by the occupational physician is to convince those involved that they each have a role to play in an organization's return to work program. Return to work programs do not just end, they are but a beginning to existence of workplaces who value their employees as contributors, partners, and pillars of the organization. Thank you for your time. Again, I wish you a good day. Stay safe.
Thank you, Dr. Rajan, for that very informative talk. So Dr. Rajan will now take questions from the audience. So there's a question here, Dr. Rajan. So how are mental health diagnoses such as depression and anxiety viewed by occupational health in this country? In our local industries, are they seen as justifiable conditions for absence from work, or that needs to be properly accommodated by employers? And have you found resistance in the industry to treat mental health disorders as a debilitating condition?
First of all, thank you. I want to apologize for the monotone during the presentation. This is my first time I'm doing a video presentation. So it was quite a challenge, I must say. Now, coming back to this question, I think I must apologize. I have not worked in this country for the last 12 years. So I will not be able to answer with respect to what's happening in Malaysia. But in the country where I worked prior to coming back to Malaysia, mental health is looked at very, very importantly. Most of our companies, or in places where I have worked, most companies have a very workable employee assistance program. Mental health is looked at as any other injury. It's treatable. The same kind of support that is given for a physical injury is given for someone who presents with any form of mental illness. We do accommodate employees in every possible way to ensure that they can remain fully functioning using the resources that we provide as well as resources that are out there in the public sector. So unfortunately, I can't answer this question with reference to Malaysia.
Okay, are there any more questions from our audience?
Yeah, I have one. Not so much a return to Dr. Rajan.
Sure.
Suyin here. Hi. Thanks for the talk. We rarely get a chance to do a Q&A with an occupational health specialist, actually. So I'm going to ask you. It can be very challenging for medical staff, healthcare professionals who have a handicap or who are disabled, actually, in their work. And actually, I have a medical student who has a hearing hearing and speech impediment, actually. Speech impediment because of his hearing. So he wears a hearing aid. And I'm very well aware that there are a lot of challenges that he will face. I mean, currently we adapt to him very easily, but in the workplace, it's not going to be very easy at all when you start as a houseman and all that. You know, what advice and what kind of sort of adaptations have you encountered a sort of similar situation where the work, you know, as a doctor is going to be very demanding for someone like him?
Right. I was very fortunate to work in a sort of a multinational company where we looked at disabilities in a big way. In fact, we had one employee in our office with multiple sclerosis. And essentially, it's basically we supporting that employee with all that he needs, that he can function as any other employee in the workplace. So for this specific employee, for example, he was using crutches to move around. So we had to make sure his desk was situated close to the fire escape because his eyesight was being affected by the sclerosis. He used to have a larger screen. We made sure his access and egress from the workplace was very well monitored. We ensured he was getting the right sort of treatment with the neurology doctors. So it's essentially the employer or the people whom he works with. We want to sort of give him that impression that, yes, you have a disability, but this disability is not limiting you from performing to your very best. And whatever we can do in the workplace to support you on that will be provided. So like I said, I was very fortunate. I came from a big company where we are able to do all of this. But I do understand that there will be the smaller companies, the small and medium scale industries who may not be able to do this. And that's when education and awareness comes into place. We need to constantly sort of explain to these groups of companies that, okay, this person has got a disability but he can still perform. We need to make some workplace accommodations. And then it's down to the employer whether they are willing to go that extra mile to sort of put these workplace accommodations in place.
True. I think we can say that we are probably not as lucky in Malaysia as other countries when it comes to access for disabled people, and even making, you know, going the extra mile to make the accommodation for someone at work who is disabled. I think that's quite, you know, it's quite rare to come across in a lot of places here. I think we're sort of still quite far behind. More so if the work is very challenging, and if, you know, someone like a doctor has to start work in a public hospital, in a government hospital, somewhere rural, it's even, you know, it's what accommodation I'm going to potentially make for, you know, for these, for his handicap. It's not necessarily going to be easy, is it?
I mean, to be honest, in this specific case that you have spoken about, this young doctor who is having a hearing impairment, I mean, it is going to be a challenge wherever he's going to be posted. But his employer, that is the Ministry of Health in brackets, well, then it's up to them to sort of ensure that they recognize or they understand that this is his issue. These are the limitations. This is what we can do to ensure that he can perform to the maximum. And wherever he's going, it's to sort of communicate to the people at the other end. His new head of department, the head of the hospital, and they, to be very honest, they need to come together. They need to get on board and say that we will go that extra mile.
Yeah. Is it a requirement by law for all employers to have a health declaration form for the employees to fill in?
Like in our company, we used to do a sort of a medical examination, which is very private and confidential. So your health declaration per se is not shown to the employer. However, if there is a health issue which we feel can impact the work journey, we will get a sort of an approval or a written statement from the potential candidate to say that he's got no objections for us to share this information, and then use this information and let the employer know, listen, he can do the job you want him for, but there are some physical limitations. And for that, we need to have A, B, C, D in place. And as I mentioned, I was in a company where this was very well received, and they would all the time say, yes, go for it.
Yeah. So the onus really falls on the employer.
Exactly. Because at the end of the day, all work sort of conditions, applications will lie with the employer.
Thank you, Dr. Rajan.
Thank you. Yeah. Thank you, Dr. Rajan, for your comments and insights. For the benefit of time, we will now move on to our third oral presenter for this afternoon. So I would like to welcome Mr. Mohammad Junahi from Arabian Gulf University, Kingdom of Bahrain, to tell us about his study on wearable technologies. Dr. Guharajan and I will be the judges for this presentation. So welcome, Mohammad.
Hello, everybody. I'm glad to have the opportunity to discuss and present our research with you today. I'm also going to thank my brother Abdulrahman and my colleagues Sarah, Yusuf, and Turkey from Saudi Arabia, my doctors, Dr. Amar from University of Petra, Jordan, and Dr. Haytham, who works in both our university and in the Ministry of Health and the Kingdom of Bahrain. So our research topic is about attitude of the adult general population towards wearable technologies and its implication to health in the Kingdom of Bahrain. For the objectives, our study aims to increase the knowledge about the adult Bahraini population's attitude towards wearable technologies, and also to assess the sleep quality and body mass index BMI in wearable users, so that we can identify if there is any difference between the two groups, those who owned and those who didn't own a wearable. So as you know that wearable technology has been involved almost in every aspect of life, especially with internet connectivity. It has improved education, health, hospitality services, labor, and many more. Nowadays, the wearable technologies market is showing a massive growth, and it is expected to show a greater growth in the following couple of years. According to IMS Institute for Healthcare Informatics 2015, they said that until 2015, more than 165,000 health-related apps were available on the market. The vast majority of these apps are designed to improve general wellness and lifestyle by making users aware of their daily caloric intake, activity, tracking sleep cycle, and female health. So our study was a cross-sectional study, and the data was collected from the general population of Bahrain. Our inclusion criteria was those who age between 15 to 64 years of age and participants using wearable devices without any medical illness. So, of course, our exclusion criteria was anyone who didn't meet the required criteria or anyone who had any past medical or psychiatric comorbidity. So, as we said, that anyone who was below 15 or above 64 years of age or had any past medical or psychiatric history was excluded from our research. This comparative cross-sectional study was drafted, acquired, and designed, and also sent to people using Google Form, which is a web-based survey. The data were collected between August and September 2020. The questionnaire was distributed through social media platforms like WhatsApp, email, and Facebook. So at the end, a total of 1,092 contacts met our criteria and included in our research. Furthermore, the Pittsburgh Sleep Quality Index is used to assess sleep quality. And for the BMI, the body mass index, we put two questions, one for the weight in kilograms and the other one for the height in meters. and then we calculated the BMI from these numbers. Self-reported anthropometric measures have consistently shown to be a valid approach to collect data. So for the data analysis, it was conducted using Stata version 16.1 to cross variables according to several criteria. The statistical test p-value, as you all know that the p-value which is equal or less than 0.05 is considered significant. Demographical statistics, the majority of our sample age was between 18 and 35 years, comprising of 43.6% of our sample, which makes sense because youngers all want and like to own wearables more than older or elderly. According to gender, male and female numbers were nearly equal. 560 males, comprising 51.28%, and females were 532, which comprised 48.72% of our sample. The single numbers was double than the married, so 63.64% were single, while only 36.36% were married. The majority of our sample educational level was the secondary level, which was 66.3%. For the BMI classes, the least class was the underweight class, which was 7.98%. And the rest were equally or nearly equally distributed in other classes. 30.55% were normal, 22.36% were overweight, and 32.11% were obese. For the smoking status, the majority were non-smoker, 71.34%. And for those who acquired or not acquired wearable, the 42.67% of our sample acquired our wearable, while 57.33% didn't acquire our wearable. For the PSQI score, the 55.7% had good sleep, while 44.3% had poor sleep. So, results of reasons among those who didn't wear wearable devices. Actually, before conducting our research, we thought that the price will be the most or the biggest factor preventing people from acquiring a wearable. But from our data, after we saw the results, we saw that the price was the least, while the product reliability, lack of suitable technologies, and more than one device to carry with the size were the biggest hesitations among those who didn't have wearables. So the type of wearables acquired and those who owned a wearable, the smart glasses, smart video, and photo was the most or the most type acquired, 45.3%. And we put the smart glasses, smart photo, video in one category because they were related to each other. The most of our sample who owned a wearable used the wearable once every 2 to 3 months. For the familiarity with the acquired wearable, 11.8% were unfamiliar, while 13.1% were extremely familiar, and the rest were in between. So the preferred body size for wearable were face and neck and waist. And the most important feature for users here is the price and value. Here we don't mean by the price that the price will be an obstacle from acquiring a wearable, but it will be a factor that change your mind and acquiring a wearable depending on the price. So if you may not take the expensive one, you may take a cheaper one, but you will still take a wearable. So most important health features for users was the notification feature, like calls, SMS, social media, and other things. Association between wearing wearable devices and BMI and sleep. So there was no significant difference between both groups, those who owned and those who didn't, according to BMI score, which was 0.2%. While there was a significant difference between them according to the PSQI score, which was 0.005. The frequency of usage, there was no significant difference between them depending or according to frequency of using. Also, there was no significant difference between them in the familiarity with own device. Other factors like smoking, educational level, martial status, gender, also there was no any significant difference in each of them. So smoking p-value was 0.45, which was not indicating that there is no significant difference between them. Educational level 0.4, martial status 0.5, gender 1. So to conclude, using wearable devices with the aim of monitoring health measures and improving lifestyle is useful. Yet the present study showed no association between using wearables, the frequency of usage, and the familiarity of users with their own devices and sleep quality and BMI in the adult Bahraini population, even though the majority of users are familiar with their devices. This may be attributed to the fact that the vast majority of our respondents use wearables very infrequent, and only around 10% of wearable users use their devices on a daily basis. So at the end, this research lies in being the largest in terms of sample size in the region up to our knowledge. Therefore, it will form a basis for future public health research to reveal the impact of wearable technologies usage on health. Thank you very much. And if you have any question, don't hesitate to ask me. Thank you.
Okay, thank you, Muhammad Janafi, for that interesting presentation. We will now take questions from the judges, Dr. Rajan, and the audience. Dr. Rajan, do you have any question?
Yes, Dr. Vivian. Thank you. Muhammad, good morning. I think it's morning in the Middle East still.
It's 10 in the morning, yes.
Yeah, so I'm right then, right. Good morning, and thank you for this presentation on this impact of technology impacting positive health behavior. I've got just one question for you, please, and that's in the exclusion criteria.
Yeah.
You had excluded those with medical and psychiatric comorbidities. Medical, I would understand because they would be more prone to wanting to use any sort of technology to improve their health outcomes. But the reason for the psychiatric comorbidity, I couldn't rightly follow, because nowadays mental health is very treatable and people can live normal lives and carry on their day-to-day living. So was there any specific reason why psychiatric comorbidities was excluded from this group?
Actually, this questionnaire was done by my doctor. He's Dr. Haytham, occupational therapist, and he works in the psychiatric department in our university. He took a sample of 1,092 using this questionnaire, and he used this sample for many studies, for many research. So I talked to him and to participate in a research, and he told me that he had a sample of 1,092, and from that we began and we wrote the paper and we did analysis and everything. So for this specific question, I can talk to him to know this why.
Sure. Sure, I understand. Thank you very much. Thank you. Thank you.
Thank you, Victor.
Thank you. Thank you, Dr. Rajan, and thank you, Muhammad Janahi. Is there any more question from the audience? All right, so can you see what's on the screen, Muhammad Janahi? So the first question is, your results showed a significant difference in the PSQI scores between those who own wearables versus those who don't. What do the results imply about sleep and owning wearables? Do you think that maybe people who own wearables tend to be more health conscious in general and may therefore practice better sleep habits?
Yes, of course it will affect like it will have an effect on the sleep quality, but our study didn't have any significant difference because those people who own the wearable didn't use it the long hours, only 1 to 3 hours a day. So it had not like affect our sleep habits in our research.
All right, thank you. And then the next question is that a high proportion of the study participants are overweight or obese. How accurately does this reflect the general population?
And sorry also for this question. I don't have specific numbers or anything because as I had said that the sample was ready before the research, before conducting the research. So the sample was ready and we began the research with the sample with us. So we wrote the paper, we did analysis, and because Dr. Haytham, he had many publications, 146 publications, and he had like this sample, he had used it for many research. So this one of them.
All right. Okay. Any more questions from the audience? I just have one question because regarding one of the tables showed that with regards to the frequency of usage, there are wearables that are, the highest frequency of use like every 2 to 3 months. May I know what type of wearable is that and which wearable are often used daily by your participants?
You mean which exact wearable?
Yes.
We didn't include that question in the research, but as a general question, 2 to 3 months, a general question. In the questionnaire, it was how often do you use it? So we didn't specify which wearable.
All right. Okay, thank you. Any more questions from the audience?
So to clarify, yeah, a little bit related to what Dr. Vivian has asked. Thank you for your presentation, Mohammed, Dr. Sain here. Did you do a subgroup analysis for the fitness tracker wearable, just the fitness tracker one? Because the health benefit of the other devices, like that you listed as smart glasses or smart clothing, the health benefits are very clear to me. And I would not expect any obvious benefit in terms of weight and sleep from those wearables.
No, it's a general analysis of a general wearables, all wearables, not a specific fitness tracker or anything. So no sub-analysis in our research. And we also submitted our research in Journal of Public Health Research, and the peer review was in the February 2, maybe 2 weeks ago or 3 weeks ago, and it's in review in the research and the journal.
Okay, all right, thank you. But maybe it would be interesting to see just in that subgroup, isn't it? There may be some differences in sleep and weight if you focus on those who use fitness trackers.
Thank you.
Yeah, I agree with Dr. Suyin. Are there any more questions from the audience? I think we still have plenty of time before we move on to the next presenter. Okay, I think if there are no further questions, then I think we can move on. Thank you, Mr. Mohammed Janahi, for that interesting presentation. So now I'd like to welcome our fourth oral presenter. It is already available, Mr. Ryan Oducado, a postgraduate student from West Visayas State University College of Nursing, Philippines, to present his study on the role and impact of resilience among nursing students dealing with COVID-19. Dr. Guharajan and Professor Chong will be the judges of this presentation. Welcome, Ryan.
Good afternoon. Can you hear me?
Yes, we can hear you.
Okay, there you go. Okay. For a while. Okay, so good afternoon, everyone. Let me present to you my study entitled Protective Role of Resilience on the COVID-19 Impact on the quality of life of nursing students. I am Ryan Michael Adocado. So for the introduction, mental health have become critical issues during the pandemic. The COVID-19 outbreak has greatly affected the lives of nursing students. With the countless of problems encountered by students, resilience, or the ability to bounce back, or to overcome adversity and to cope effectively with problems is a key component to recuperate and recover from distress and issues. Previous studies conducted before the pandemic have shown that resilience is a buffering effect on the and stress of nursing students. However, the role of resilience on the impact on the quality of life concerning mental health in the context of the COVID-19 pandemic among nursing students has not been explored or investigated. Hence, this study was conducted to determine the influence of personal resilience on the impact of COVID-19 on the quality of life of nursing students, look into the differences, correlation, and predictive power of the selected independent variables on the dependent variable, which was the impact of COVID-19 on the quality of life of nursing students. So we use a cross-sectional research design, and we have conducted an online survey administered from August 18 to 31 of 2020. There were 345 students, nursing students in one government-funded nursing school in the central part of the Philippines that participated in this survey. And we have obtained a total of 59.38% response rate. So we use the Brief Resilience Scale by Smith and the COVID-19 impact on the quality of life by Ripisti to assess the resilience and impact on the quality of life of nursing students. We asked permission from the authors and the developers of the instruments, and we were granted permission to use the scale. So the Brief Resilience Scale and the COVID-19 impact were found to have acceptable internal consistency with a Cronbach alpha of greater than 0.7. So we also included and gathered the profile of the participants in this study. For data analysis, we use the SPSS version 23, and we use descriptive statistics such as frequency, percentage, mean, and standard deviation to describe the data. To assess the differences between variables, we use the t-test for independent samples and one-way ANOVA. And Pearson's R was used to correlate selected variables. Then stepwise multiple linear regression was used to identify predictors of COVID-19 impact on the quality of life of nursing students. The alpha level of significance for this study was set at 0.05. So this study was approved by the San Beda University Ethics Review Board with protocol number 2020-041. So this is the demographic profile of our study and the descriptives of the independent variables. So if you can see in the table, the mean age of the participants was 19.92, approaching 20 years old. Majority were females, which is given that nursing is a female-dominant profession. In second-year level, living in rural areas of the province, reported the presence of a COVID-19 case near their residence and had no medical condition that might increase their risk of COVID-19 illness. Most of the students had an estimated family income of less than 400 USD, given that our study population was conducted in a government-funded university. So the composite score in the brief resilience scale was 3.04, indicating about moderate resilience. So for table 2, shows the composite score in the quality of life scale was 3.35, suggesting a moderate extent of impact of COVID-19. Also, the COVID-19 pandemic had the highest impact on nursing students' patients' safety and had the lowest impact on nursing students' feeling of depression. So in table 3, it is shown that there were significant differences in the COVID-19 impact on the quality of life of nursing students based on sex, which we can see by mean that female nursing students were more affected by COVID-19, and likewise the presence of COVID-19 case near their residence. Those who had reported presence of COVID-19 case near their residence and who were unsure of the presence of COVID-19 case near their residence reported higher impact of COVID-19 on their quality of life. The bivariate analysis also revealed that there was a significant relationship between personal resilience and impact on COVID-19 on the quality of life of nursing student, and the relationship was found to be an inverse or negative relationship. Furthermore, stepwise linear regression analysis indicated that resilience was a significant predictor on the impact on quality of life of nursing students. Moreover, resilience explained 13.2% of variance in the COVID-19 impact among nursing students. So the results suggest that the higher the resilience, the lesser is the impact of COVID-19 on the quality of life of nursing students or vice versa. This is consistent with other studies disclosing the inverse or negative association between resilience with patterns of COVID-19 stress, fear, anxiety, and depression, which was conducted with other population and in other countries. So for the conclusion, the COVID-19 outbreak has eventually affected the quality of life of nursing students and is casting concern not only on the physical health and safety, but also on the psychological health and well-being related to quality of life. Additionally, female nursing students and those who are in a nearby presence of COVID-19 case or unsure of a COVID-19 case near their residence are more vulnerable to the impact of COVID-19 on the quality of life. Further, our study highlights the protective role and the cushioning role of resilience on the impact on the quality of life in the context of COVID-19 pandemic. Resilience is a vital factor of personal resource that makes nursing students less susceptible against the negative impact of COVID-19 outbreak, at the same time helps reduce the adverse impact of the COVID-19 pandemic among nursing students. Failure to recognize the negative impact of the COVID-19 pandemic and other major life events on the quality of life of nursing students may result in detrimental consequences. So resilience can be seen as a dynamic adaptation process. Hence, students can be potentially trained to harness their resilience trait. Therefore, understanding the factors and developing strategies that build the resilience of students is a focal point of action for academic institutions. This study, however, is without shortcomings or limitations that could be addressed by further studies. This study only involved nursing students in one nursing school in the Philippines. Hence, the study findings cannot be generalized to all nursing students, both locally and internationally. The research design, which is cross-sectional, cannot conclude the causal effect among the study variables. So we do not say that resilience has an effect on COVID-19 impact. We simply look into the correlation between the two variables. Likewise, our study cannot track temporal changes over time. So it may be good for other future researchers to study again and look into the impact of COVID-19 a year after the COVID-19 outbreak. Also, the use of online survey lends itself to social desirability and self-reported bias. So given the limitations, we warrant the researchers to use caution in using and interpreting the findings of this study. Nonetheless, we believe that our study contributes to a better understanding on the impact of COVID-19 pandemic on the quality of life of nursing students. So we declare no conflict of interest. We did not receive any funding for this research study. We would also like to acknowledge all nursing students who participated in our study. And if there are any questions after this conference, you may contact me through my email. So these are my references, and thank you very much for listening to my presentation.
Thank you very much, Ryan, for that very interesting and informative talk. I will now give the floor to the audience or to the judges, Dr. Rajan and Prof. Pepe Chong, if you have any questions.
Professor, do you mind if I go first?
Yes, it's okay, Dr. Rajan. Please go ahead.
Thank you very much, Professor. Hi, Ryan. Good afternoon. Thank you for your presentation. Excellent. I've had the opportunity to visit your country many times, both on work and also to Tacloban post the natural disaster that took place some time ago. And your population is very, very resilient, believe me. Very, very resilient. I've actually got two sort of, I don't know if it's a question or a comment. I think the first one is this, one of your results states that female nursing students, let's see now, they had a, I mean, in your results, let me see, something on the female students findings. Yeah. Female nursing students are more vulnerable to the impact of COVID-19.
Yes.
Now, would this mean that, I mean, could this be due to the fact that, you know, when you got your population sample, the number of females as opposed to males, there was a huge disparity there? Could that be one of the reasons?
That could be one of the reasons, doctor, but when we review the literature, actually, this finding is also consistent with the literature, given that females are usually vulnerable to stressful life events, not only with this pandemic, even studies prior to the pandemic and also studies during the pandemic have shown that female nursing students are more affected compared to male students.
Okay, Ioantina is very careful. Okay, my second question is on your table 2. There was this question on, I feel more depressed than before. And
yes.
How did you qualify this to the participants, you know, for them to say, I feel more depressed than before? What were the sort of signs or symptoms that they would use as an indicator to sort of answer that question?
I believe that nursing students are oriented about the mental health problems. So this was just the COVID-19 impact on the quality of life is only composed of 6 items. We have adopted this from Ripisti. So which was found to have highly valid and reliable bid among when assessed among both clinical and non-clinical samples. So I think that would be one of the limitations of our present study.
No problem. Thank you very much. Thank you. Thank you.
Thank you, Dr. Rajan.
Yeah. Thank you, Dr. Rajan. Prof. Pepe, you have a question?
Yeah. Yes. Thank you, Dr. Vivian. Ryan, thank you for the very interesting presentation.
Thank you, Dr. Chong.
Very timely as well. I have 2 questions because I'm not in this field, so I'm curious what kind of questions are asked in order to determine the resilience in the questionnaire.
This is actually a 6-item resilience scale by Smith. This is also an adopted questionnaire. It was they asked about if students are able to bounce back after a problem, if they are easily, or they can easily bounce back to their previous mental state without any other complaints. So those are some of the questions that were asked on the resilience scale, and it was found to be highly internally consistent. So if they can be flexible or resilient enough, or they can be adaptable to any circumstances that they face, if they do agree or do not disagree on that.
Right. Okay. Thank you.
Are some of the questions.
Okay. Another question is, when you performed this study, was the area that these students residing in, was it under movement restriction? And did you look into whether movement restriction was also a factor that influenced their QOL, their quality of life?
Actually, we in the Philippines until now we are still in the movement restriction, but when we conducted this in August, it was more lax already. It was not already on a tight community quarantine, but there were already times when students people are now allowed to go out of their houses, unlike during April or May. But this if community quarantine affects the quality of life of nursing students, this will not assess in if at present during the time of our survey there were current cases, present cases near their residence, but we did not ask them if quarantine guidelines affected their quality of life. Nonetheless, it could not be readily assessed because these students belong in a similar geographic location, in which in the Philippines our lockdowns is usually per area guidelines.
Yeah, I was just thinking maybe that could be something that you could look into as well in the future, because some students, like you said, if the lockdown is according to the areas or the regions, maybe those who are in areas where there's lockdown, could that be a factor that also influence their the quality of life that you want to measure?
Yes, doctor.
It's just a suggestion. Okay, I think those are my 2 questions. I would like to pass back the time to Dr. Vivian.
Thank you, Prof. Chong. Okay, so there are 2 more questions here, unless anyone would like to ask question before I ask this.
I have a question actually for Ryan. Hi, Ryan.
Hello, Dr. Lim.
Nice to see you. Nice to see you made it.
Thank you for accommodating my request.
Oh no, it's okay. Our pleasure. So I liked I like how you presented your results. Very important topic, and I think it even though it focused on the nursing students, it's very relevant to our population elsewhere as well. Just out of interest, I noticed that in your table you looked at you compared the quality of life scores between those who they knew that there were cases nearby.
Yes.
And then those that didn't know, and then those that were unsure. But
Yeah.
that was a positive result. It was significant. I think you did an ANOVA test, right?
Yeah.
But with the ANOVA test, you don't know which pair of comparison is significant. Like, was it between? I was interested. So those who didn't know if they had
I did a post hoc. I did a post hoc analysis. I did a post hoc analysis. So it was significant. I was not able to show it in the presentation because I know it's brief, but I did a post hoc analysis. It was significant between those who are those who have no cases and those with cases, and those with unsure and those without cases.
Between those who are unsure as well, because I was wondering if uncertainty made you more anxious, or was there not much difference? It made you as
there was
anxious
not.
One who knew about.
No, there was not. Actually, those who were more anxious were those with uncertain. Yes, there was those who were without and with unsure. There was a significant difference.
That pair was also significantly different.
Yes,
okay.
there was a significant difference. I saw another study that spatial distance to COVID-19 cases supports also our study that it actually, if you know that there is someone near your neighborhood, that there is someone actually a COVID-19 case, increases actually anxiety and fear. And actually there were some reported cases here in the Philippines that some of those have that stigma is very high in that area, in that case, that when there is someone who would be noted as there is a case there near their residence, and then they will get stigmatized. There were really even reports that some students were not able to go back to their boarding houses because they were feared that they are bringing COVID to their boarding houses.
I think it's very similar everywhere, actually. I can imagine that we did a survey here. I think we might find very similar results. So in that way, I think it's quite generalizable, even though you say it's not generalizable. But I think the situation is very similar, isn't it? To hear.
Yes, Dr.
Thank you, Ryan. Thank you.
Thank you, Ryan, for that insight. Okay, so I have 2 more questions here. So the first is, in those who said that they had underlying medical conditions, do you know what these conditions were?
Yes, they mentioned that, but majority would have asthma.
Oh, I see.
Yes, asthma for this students that they mentioned that they fear that that could potentially affect their
risk
of getting
COVID-19
severe COVID-19 illness. But the impact was not statistically significant in our findings. Maybe because it was highly skewed. It was very small. They are a very small proportion.
All right, thank you. The next question is, what are the key components of the brief resilience scale and how is it scored? Is it a Likert scale or a composite score? I think you mentioned this, but you can probably tell us again.
It is a Likert scale. It's a 6 items. We adopted it from Smith, with 1 strongly disagree to 5 strongly agree. There are reverse scoring to items that are negatively stated, and higher scores indicates higher resilience. But for our study, we we look into the interval between low, moderate, and high, and we created an interval between 1.00 to 2.33, 2.34 to 3.66, 3.67 to 5.0 as high resilience, because when we contacted the author, there was no concrete interpretation of the findings. But nonetheless, if we can see that the mean score is 3/5, it's on a moderate. It's in the middle scale between. So it can be interpreted as a moderate resilience among nursing students.
Right, that's nice. Okay, so I think we still have enough time. So if there are any more questions from the audience before I move on to the next speaker. Okay, so I think there are no more questions. Thank you, Ryan.
Thank you very
also,
much.
yes,
Thank you.
and thank you also to the previous speakers and the previous oral presenters for this session. So occupational safety and health is paramount to the well-being of our healthcare workers, and even so more during the current pandemic. So we will now have my co-chair, Professor Dr. Chong Pei Pei, present her talk on the COVID-19 diagnostics. Professor Chong graduated from UMIST, the University of Manchester in UK, with a first-class honors degree in BSc in biochemistry, and later on went on to pursue her PhD at the same university. She is chiefly a molecular biologist who adopts the molecular and omics platforms to solve problems in infectious disease diagnosis and fundamental questions about the role of viral etiology in pre-malignant conditions and carcinogenesis. She was involved in a collaborative research in various fields, including microbiology and infections, and cancer and genetic susceptibility. Prior to joining Taylor's University, she served with the University Putra Malaysia for many years and had held the position of acting Deputy Dean of Research at the Faculty of Medicine and Health Sciences. She had also worked as a visiting research associate professor in National University of Singapore. She has been actively involved in collaborative research with the Hospital Sungai Buloh and Institute of Clinical Research NIH, Ministry of Health Malaysia on COVID-19 research since last year. Due to this reason, she had been also following closely the efforts by various countries in the world on the development of COVID-19 vaccines. So welcome, Prof. Chong.
Good afternoon, everyone. I'm Prof. Dr. Chong Pei Pei, Head of Research at the Faculty of Health and Medical Sciences, Taylor's University. I would like to thank the organizing committee for inviting me to give a talk in this webinar. First of all, a big salute especially to the medical colleagues and frontliners who have worked hard in our concerted effort to battle against the COVID-19 pandemic. The title of my talk is Understanding COVID-19 Diagnostics. The content of my talk today covers the following aspects: the different formats of diagnostic assays, the focus on RT-qPCR assays, and the different target genes, the WHO guidelines for COVID-19 diagnostics, and following that, I will show you the comparison of various RT-PCR tests currently available and compare their specificity and sensitivity very briefly. Next, the types of specimens used for testing will be described. And then I will move on to the serology assays and their view or role in diagnostics. And then the radiology or imaging findings and also their value in COVID-19 diagnostics. The last topic will be about the biomarkers for diagnostics. And finally, I will conclude the presentation by summarizing the main points and some ideas about future research on COVID-19 diagnostics. Okay, there are several commonly used SARS-CoV-2 diagnostic approaches, including history taking or physical examination for signs and symptoms. Next, we also have imaging findings, such as chest x-rays, CT scans, ultrasounds, MRIs. The molecular assays is the third approach, which comprise mainly of RT-qPCR tests, and we also have the immunological assays. So development of a reliable assay has been one of the hallmark methods for public health and clinical interventions. Currently, nucleic acid assays by reverse transcription real-time PCR or RT-qPCR, Q stands for quantitative, is the main approach for COVID-19 diagnostics. For the RT-PCR assays, which specific genes are selected as the target region for the assay is really crucial. The E gene of the SARS-CoV-2 virus has been shown to be highly similar to that of other coronaviruses, which leads to its use as the first-line screening tool. In addition, the SARS-CoV-2 has low homology with other bat-related coronaviruses in terms of its OF1B gene, which also involves the RDRP gene. Besides that, we have the N and the S genes, which are relatively specific, or they are so-called the unique genes that help to diagnose the COVID-19 definitively. In clinical RT-PCR protocols or assays, some tests involve the use of single target and some use multiple target. Since the SARS-CoV-2 virus is a single-stranded RNA virus, which is prone to mutation, increasing the number of specific targets in the RT-PCR system will increase the testing sensitivity and also the specificity. However, if the primers are not specifically designed, multiple targets in the PCR system could interfere with each other, reducing the amplification efficiency and clinical sensitivity. Therefore, selecting an appropriate number of targets for the RT-PCR protocols depends on the detection purpose, the specific primer sequence chosen, and the results of the performance verification. The WHO has published the guidelines to the COVID-19 diagnostics. Many in-house as well as commercial assays for detecting the COVID-19 virus have been developed, as shown in this table. Most of these tests detect not just single targets, but multiple targets. For example, the US CDC has an in-house test that detects 3 targets in the N gene. And for Germany, their tests detect 3 different target genes, the RDRP, the E gene, and the N gene. There are at least 50 different RT-PCR test kits that have been developed for COVID-19 testing. These tests have varying sensitivity and limit of detection, and they also target different genes of the virus. So this table shows some of the tests that have been developed by different companies and also by CDC. And you can see that all these tests target different genes of the virus, and they have varying limits of detection. This is a schematic of the process flow for RT-PCR testing. Step 1 is swab sample collection. where the most commonly collected samples are the nose swabs or nasal swabs, and also the throat swabs or pharyngeal swabs. Step 2 is the extraction of RNA from the samples that have been collected. There are different methods according to the different RT-PCR kits, and the duration of this step varies from 30 minutes to 2 hours. Step 3 is the RT-PCR step, where the reactions are set up to detect the viral nucleic acids using specific primers, and then the reaction vials are placed into the real-time PCR machine, and the reaction setup itself may take between 1 to 2 hours or more, depending on the number of samples to be tested. The PCR run in the machine takes about 2 hours. Step 4 is the interpretation of the results, and in cases where the results are inconclusive or borderline, the test may be repeated. Different types of samples for RT-PCR testing have been used. It was found that types of the samples play a key role in the ability to produce a positive RT-PCR result. It has been found that viral loads of respiratory tract specimens are highest in the bronchoalveolar lavage fluid or BALF, followed by the sputum, nasal swabs, and pharyngeal swabs. Zhou and colleagues found that the positive detection rate of nasopharyngeal swabs in 14 of 18 patients was higher than that of the oropharyngeal swabs, and the PCR cycle threshold value of the former were also lower. Meanwhile, Liu and his colleagues revealed that nasal and pharyngeal swab samples exhibited a lower positive rate compared to BALF and sputum samples. In addition, a recent study by Wang and colleagues evaluated the positive detection rate of more than 1,000 different specimens collected from 205 infected patients, and their results revealed that the positive rate of the BALF was highest, followed by the sputum samples, and then the nasal swabs, and then throat swabs, stool samples, blood, and finally urine. Therefore, if multiple sampling methods can be adopted for the patients, specimens with a high positive rate such as BALF or sputum should be selected preferentially. But having said that, collecting BALF requires complicated procedures and is not suitable for all patients. And many patients have non-productive cough, so the feasibility of sputum sampling is also low. Therefore, nasopharyngeal swabs have been the main sample choice for clinical testing. However, for nasopharyngeal swabs or NPS, it is an invasive procedure, causes discomfort and fear for the patients, and is not amenable for the pediatric population or the children. It also requires well-trained healthcare workers to execute, and it requires the use of personal protective equipment, which could be costly. Saliva is another specimen which have been researched intensively in the past few months. Saliva has the advantage of being a non-invasive specimen, causes no pain or discomfort, and self-collection of the specimen is possible. The utility of saliva for SARS-CoV-2 detection in hospitalized inpatients as well as outpatients have been shown. And besides that, community or mass screening using saliva specimens have also been demonstrated. In one particular paper I read, saliva has been used for the inbound travelers in an airport, and it was found that saliva gave a very reliable result compared to the nasopharyngeal swab. Some studies even showed that saliva had a higher positive detection rate than the NPS swab. My colleagues and myself, we have performed some collaborative study with the Hospital Sungai Buloh on hospitalized pediatric patients. So we showed that even for the pediatric population, saliva specimens showed good sensitivity of about 81% positive rate. And both asymptomatic and symptomatic patients were able to be diagnosed via the saliva RT-qPCR. What about the role of serology assays? Does it have any value at all for COVID-19 diagnostics? So we know that serology tests have the aim of detecting individuals who have had previous infection and therefore theoretically developed immunity. The time course and the accuracy of serology tests are important, and although they are slightly different in different studies, generally the immunoglobulin IgM indicates the acute infectious stage and is usually detected around a median of 5th day of the course of illness, while the IgG represents middle and late stages of infection or even previous infection, and it's been shown to be detected around a median of 14 days of illness. Antibodies represent the host humoral response against the SARS-CoV-2 infection, indicating the status of infection. Therefore, serological antibody assays can be used in a diagnosis of suspected cases, okay, in combination with molecular testing or for additional testing in suspected cases with negative RT-PCR results. Moreover, the levels of the IgG and IgM against the S and the N proteins of the virus were found to be correlated with a virus neutralization titer. And a high titer of antibody was independently associated with a worse clinical classification. So these data suggest the potential value of antibody titers for evaluating the prognosis and the recovery of the patients. So we can say that the serological assays are useful for evaluating the prognosis and recovery of patients, and maybe also for the purpose of community surveillance to see the percentage of population that has developed herd immunity. So this table shows some of the serology kits that are commercially developed, and from these findings, the IgM and IgG assays had a sensitivity and specificity that varies between 80% to 90%. Now, chest imaging, which includes chest radiography, computed tomography, CT, and lung ultrasound, have been investigated for their value for COVID-19 diagnostics. The diagnosis of COVID-19 in some countries is confirmed by laboratory testing through identification of viral RNA in conjunction with the imaging. WHO lists several scenarios whereby chest imaging should not be used, and also other scenarios where the use of imaging is warranted. Chest imaging has been considered as part of the diagnostic workup of patients with suspected or probable COVID-19 disease where the RT-PCR result is not available or the results are delayed and you need the urgent diagnostics or test, and or initially negative in the presence of the symptoms that are suggestive of COVID-19. So, imaging has been also considered to complement clinical evaluation and laboratory parameters in the management of patients that are already diagnosed with COVID-19. Some patients with positive chest CT findings showed negative molecular results from the mouth swabs, and after repeated testing from mouth swabs, they were finally confirmed to have the infections. Infected patients may present with any of a plethora of highly general symptoms like fever, cough, myalgia, sputum production, headache, diarrhea, dyspnea, and in some cases, acute respiratory distress syndrome or acute cardiac injury. These subjective clinical symptoms can be interpreted more confidently with the use of biological markers or biomarkers. Here are some of the different biomarkers that have been shown in studies to play a role in the disease pathogenesis of COVID-19 and have potential in applications of diagnostics. So these include C-reactive protein, serum alpha amyloid, interleukin-6, D-dimer, lymphocytes, and platelet count. This table on this slide summarizes the biomarkers discussed in the presentation in the previous slide. The levels of these biomarkers can increase or decrease according to the severity of the disease or the progression of disease. For example, the CRP, the SAA, IL-6, LDH, D-dimer, and cardiac troponin have been shown to increase in severe COVID-19 infection, whereas the other biomarkers have shown a trend of decrease. So what can we conclude from all this information? Accurate diagnostic assays can offer a robust approach for the timely identification of infected individuals, and this is key to preventing transmission of the viral infection. RT-PCR is widely employed in the molecular diagnosis of SARS-CoV-2 infection, and it is considered a confirmatory diagnostic assay of active infection, regardless of whether the individual is symptomatic or asymptomatic. Dynamic serological antibody assays can be considered as supplementary methods which can indicate a mid-stage or a late-stage infection or even a previous infection. Viral nucleic acid and antibody concentrations fluctuate in different infection stages, suggesting the infection stage may be determined using a combination of molecular as well as serological assays. Chest imaging has value in complementing the other modalities of testing, and the chest imaging as well as the biomarkers, which can be used in conjunction with CT scans for hospitalized patients. They can help in the clinical decisions for triaging patients, for deciding which clinical management that they should be implemented. And for future directions, currently several different formats of diagnostic assays are under development. So these include the RT-LAMP, which is a loop-mediated isothermal amplification. This RT-LAMP method is more cost-effective, more rapid, and also simpler to do. Besides that, there are also some institutions that started to look at the CRISPR-Cas system as another alternative assay format. So this is based on the gene editing system. In addition, there are some research looking at the sensor technology, utilizing, for example, the surface plasmon technology or SPR. So there are a few other alternative approaches or the high-tech approaches as well for helping to facilitate the mass screening in the population. So this brings us to the end of my presentation. Thank you for your kind attention, and I'll be happy to take any questions in the Q&A. Thank you.
Thank you very much, Prof. Chong, for the excellent talk. So molecular diagnostics is a very fascinating and complicated field, and it clearly plays a crucial role in the diagnosis of COVID-19. Professor Chong will now take some questions from the audience.
Thank you, Dr. Vivian.
So maybe I'll ask the first question.
Okay.
Something I'm quite puzzled because I'm not a lab person, so I don't quite understand when we request our PCR test, we often get positives, but unexpected positives, and so sometimes the clinician will say, "Oh, it's probably a false positive." I mean, how can we get a false positive if you're testing a really specific nucleic acid, for example? I mean, where's the positive coming from?
Okay, so technically speaking, when we run the RT-PCR test, we have to always include stringent controls. So we have positive as well as negative control. The positive control usually is already included in the test kit that we purchase from the commercial provider, or sometimes in the beginning of the pandemic, our Institute of Medical Research, IMR, actually also developed their own in-house assays, in-house molecular assay. But all in all these test kits will have a positive control containing a known fragment of the nucleic acid that would give a positive result, and also a negative sample. So we will always have a negative sample, and we also have an internal control. So all these controls have to be in place, and when the lab personnel interprets the results, they always have to look at all these different controls as the backdrop before they give the conclusive verdict for a specific sample, whether it's positive or not. But having said that, because this method is a very highly sensitive method that is based on the amplification, logarithmic amplification of the nucleic acid present in any sample. So the technical expertise and the caution should also be practiced by the lab personnel. So even a very minute amount of contaminant RNA, for example, if your pipetting technique is not very good, if you have accidentally introduced some contaminant RNA in the particular well or vial of the test format, so it could sometimes give a false positive. So that is why if there are some inconclusive results, it is advisable to repeat the test to rule out all these false positive results. And also, just to share with you, I got to know that in some laboratories, because they have to do a large scale screening, let's say thousands of screening, I heard that in some cases they pool the samples. So maybe they will have 3 samples in one well instead of 1. And then they will have an algorithm to decide, based on the results of the pool testing. They will have an algorithm to decide which sample to repeat. If a particular well shows a positive result, they will have to repeat for those 3 samples. For example, those 3 in that well that showed a positive result.
Because the risk of potential contamination is higher, it just seems too coincidental that too many in that well.
Yep.
So they have measures at least. Okay, thanks for explaining. I always used to wonder how a false positive come about. Thanks, that's very clear.
Yeah, welcome.
Okay, thank you, Prof. Chong. There is one question here from the chat. If the saliva specimen yields high in RT-PCR test, is it okay for a person to request it instead of a nasopharyngeal swab?
Yes. But having said that, we always must refer to the Ministry of Health guidelines, and they have standard operating procedures for the test and for deciding the confirmatory diagnosis. But increasingly, a lot of countries are utilizing saliva as an alternative specimen or in some cases even the substitute specimen for patients whereby the NPS is not ideal for as a specimen for testing. So I think in for the future, maybe they have to really consider using saliva, especially for the pediatric patients testing.
Currently, if you send a saliva specimen, will they accept it in the local labs, or it's still too, it's experimental and
I heard that there's plan to recognize saliva as a specimen type that is acceptable for testing. But I think currently the SOP is still based on NPS.
All right. Prof. Chong, in relation to that saliva sample, what do you think about the anal swab test used in China?
Okay, anal swab, I don't think it's that sensitive. I have also done some testing on anal swab. The positive rate was not good. I'm not confident of using anal swab.
I think it will be uncomfortable.
That too. Because after all, also, I mean, anal swab may be a way to assess viral shedding, but not active infection. So I think the oropharyngeal area is still the best specimen.
All right. And then many local labs offer rapid antigen testing. How appropriate is this test for the average patient coming for screening?
Okay. As I've explained in my presentation, so antigen, I've explained the antibody testing, sorry. For antigen, rapid antigen testing can be an alternative test format, but it's also invasive test because you have to draw blood, but sometimes you can use the what do you call that? The finger prick as well. But having but because the format of the rapid testing is always the lateral flow assay, which is akin to the pregnancy test. So the sensitivity of the test is low compared to like RT-PCR, which is very high sensitivity. So if you are tested as negative for the antigen testing, I don't you may still be a positive carrier or even infected patient because the sensitivity is not high enough. Yeah.
Okay. And then do the antibody levels in serologic testing reflect well the level of immunity to reinfection?
So far, there are some studies done overseas, and yes, they do show some correlation.
Okay.
Yeah.
All right. And then what type of tests are being used in Malaysia for our large-scale screening?
So far, the large-scale screening in the public institution, like public hospitals, still the RT-PCR is used as the definitive test. But in private labs, you can request for rapid antigen or rapid antibody tests as well for large scale screening, like for example the factories or businesses, you know.
Okay.
Yeah.
Does this RT-PCR cover the newer variants of SARS-CoV-2?
Yes, most of them do. But having said that, it is best to choose the RT-PCR test kits that target not just a single gene, but multiple genes, at least 2 different genes. Because based on my own experience as well, when I was doing the study, in some patients, they may show positive result for one gene, but not another gene. So it is best to have, and in fact, our Ministry of Health do use kits that target multiple genes.
All right.
Yeah.
Okay. Can I have the first question here in the Slido? I think the one above, I haven't asked that. Yeah, this one. Does low cycle threshold level in RT-PCR always indicate high level of infectivity?
Okay. So there's an inverse relationship between the cycle threshold or CT level with the viral load. So if you have low CT, that means your viral load is high. So that would suggest a high infectivity.
All right. Okay, the second question is similar to the saliva a while ago. How about this? What do you think about air sampling for COVID-19? Is there any research done on air sampling for virus in the air, for example, in the contained room?
I recall reading some articles where, yes, they took the air samples in the ICU ward where the COVID-19 patients were warded, and test whether, because they want to see the level of the infectivity of aerosol and the transmission from aerosol. So they did find some positive results, but of course they were using very highly sensitive tests for that. And also in Hong Kong, there were some studies that look at the environmental sources of this SARS-CoV-2 virus. Yeah, like they collected the samples from the sewage pipes in the apartment blocks, and they did show some presence of the nucleic acid of the virus in some of these studies. But the statements by these researchers who performed the study is that although they could detect the viral nucleic acids, they think that these nucleic acids are not infective anymore because of in the sewage there will be things like detergent and stuff like that, which
can kill the virus.
Yeah, that's right.
Okay.
Yeah.
Okay, any more questions from the audience? Oh, I think I've asked all those questions. Okay. Thank you. Yeah, okay, Suyin. Yeah, okay, sorry.
Oh, that's one I was just directing one in the chat box.
All right, okay.
Right.
All right. Let me see the one in the chat box. Are any markers currently that could predict severity of infection?
Okay, as I've explained, there are quite a number of markers like the CRP, serum amyloid alpha, and then lymphocyte count and so on. But by and large, these are still under investigation, and more large-scale studies need to be conducted before they can be considered as a diagnostic marker. And I don't think any single specific marker can be used definitively, and they always have to be used in conjunction with the other modes of assays like the chest finding and also RT-PCR as a holistic picture to inform the clinician. Also,
yes,
like
and the other inflammatory markers as well.
Yeah, you're right. And then to help to triage which patients to prioritize for therapy and which patient can be discharged and so on. Yeah.
Right. Okay, I think those are all the questions. Okay. Thank you, Prof. Chong, okay, for that excellent talk. And thank you for answering our questions. Okay.
Yeah, no problem.
Let's now move on to the next part.
Right. Hold on. Okay. Thank you all for your insightful questions. I will now invite my co-chair, Dr. Vivian Andaya Verbo, to tell us about the treatments for COVID-19, a highly relevant topic during this time. Dr. Verbo is currently a senior lecturer in the undergraduate medical degree program at Newcastle University Medicine, Malaysia, where she teaches pharmacology and clinical communication skills. She has been in academia for almost 15 years and has taught at various colleges and universities in the Philippines and also in Malaysia. She took up a Bachelor of Science degree in Industrial Pharmacy at the University of the Philippines as an undergraduate degree, and after that pursued a Doctor of Medicine degree at St. Luke's College of Medicine in the Philippines. She specialized in geriatric medicine at the Philippine College of Gerontology and Geriatrics and became a fellow in geriatric medicine. While in academia, she also took up a postgraduate certificate in medical education at Newcastle University, UK, and is currently a fellow of the Higher Education Academy of the UK. So without further ado, I would like to pass the time now to Dr. Verbo.
Hello and good day to all the participants. Thank you for inviting me as a guest speaker for today's event. I am Dr. Vivian Andaya Verbo. I'm a senior lecturer for MBBS program at Newcastle University Medicine, Malaysia. Today, I'm going to discuss the general management and treatments for COVID-19. Here are the aims of this lecture: to list down the symptoms associated with COVID-19 and to differentiate it from common colds and flu. Second is to describe the clinical staging of syndrome associated with COVID-19. And lastly, to describe the treatment or management of COVID-19. As of February 15, 2021, this is the breakdown of cases of the novel coronavirus infections COVID-19 in Malaysia. There is a total of 266,000 total confirmed cases, and out of that, 218,000 was discharged. So there is approximately 82% of the discharged cases from the total cases. It goes to show that the recovery rate in Malaysia is very high. This is the COVID-19 mortality statistics in Malaysia as of November 22, 2020. The case fatality rate, or the proportion of reported cases of a disease that lead to death, is 0.6%, but currently it is around 0.3%. This 0.6% means that for every 1,000 person infected with COVID-19, 6 persons might die. This value will still change as improvements in the management and rolling out of vaccination will happen at the end of this month. The case fatality rate varies according to gender, the age, and the underlying health conditions. In this slide, it shows that COVID-19 deaths occur more predominantly in males than in females. And based on the age group, 64% of COVID-19 deaths is for age 60 years and above. This is probably due to a weaker immune systems that occur in the elderly, and also at this age, the patients may have underlying health conditions. 87% of COVID-19 deaths are reported to have at least one of these underlying health conditions. Under this, we have high blood pressure, diabetes mellitus, and heart disease, which are among the top underlying health conditions. The graph on the right shows the breakdown of the symptoms and severity of the novel coronavirus infection. This data is reported by the WHO and the Novel Coronavirus Pneumonia Emergence Response Epidemiology Team. Based on severity, 81% of the cases are mild, 14% are severe, and 5% are critical cases. Among the symptoms, fever, dry cough, and fatigue are the most common. Other symptoms that are also found in COVID-19 infections are sputum production, shortness of breath, muscle or joint pain, sore throat, headaches, chills, nausea or vomiting, nasal congestion, and diarrhea. If you have noticed, some of these symptoms are also found in common colds and flu. So how are we going to differentiate COVID-19 symptoms from flu and common cold? If you look at this comparison on the right, we can see that fever, fatigue, and cough are common for coronavirus infection and flu. Fever is defined as having a temperature more than or equal to 38 degrees centigrade. Sneezing, aches and body pains, runny or stuffy nose, and sore throat are common in colds. However, if you have a sudden loss of taste and smell, it could be an early indicator of a COVID-19 and may occur even without a runny or a stuffy nose. If the patient experiences shortness of breath, which is sometimes seen in coronavirus infection, this is a warning sign of a severe symptom and may warrant hospital admission. This is the clinical staging of syndrome associated with COVID-19. In Malaysia, we have 5 clinical stages, which corresponds to the severity of the disease. In stage 1, the patient is asymptomatic, meaning there are no clinical symptoms, but he has a positive nasal swab test. For stage 2, which is the mild illness, the patients may have symptoms such as fever, sore throat, dry cough, malaise, and body aches, which is similar to common colds and flu. But there is no difficulty of breathing. In stage 3, which is the moderate illness, apart from the symptoms above, patients may have symptoms of pneumonia, that is of persistent fever and cough, still without hypoxemia. Hypoxemia means that the oxygen saturation of the patient is within the normal limits. In stage 4, which is the severe illness, patients now have pneumonia, but with hypoxemia, that is the oxygen saturation is less than 92%, and therefore they require supplemental oxygen. The stage 5 or the critical state means the patient is having an acute respiratory distress syndrome along with shock, coagulation defects, and multi-organ involvement. In terms of treatment protocols, the patient can be divided into 3 categories. These are mild, moderate, and severe. So the mild corresponds to stage 1 and 2, moderate stage 3, and severe stage 4 and 5. For mild stage or for mild category, patients may have fever or other symptoms of upper respiratory infection, but the oxygen saturation is more than or equal to 97% on room air. These patients may undergo home isolation with contact precaution. This means that the patient should isolate himself with the other members of the household. That means they need to use separate utensils, separate beddings, and separate rooms. They may also need supportive and symptomatic management. This device is known as pulse oximeter. So this detects the oxygen saturation of the patient. For moderate and severe stages, this requires hospital admission. So most of the cases that we see for COVID-19 are mild cases. So for mild cases, there are no specific treatment, but treatment protocols may differ from different countries. But in general, supportive or symptomatic therapy are the management for mild disease or mild illness. For fever, body pains, and headaches, we can give analgesics and antipyretics. Paracetamol is the preferred drug for this. For cough with phlegm, we can give mucolytics such as carbocysteine to loosen out the phlegm. But if the cough is persistent or interferes with sleep or causes discomfort, we can give dextromethorphan. For sore throat, we can give antiseptic mouthwash or gargle, throat lozenges, and saline gargle. Saline gargle can be prepared by adding 1 teaspoon of salt in a glass of water and use it as a gargle. Salt is not only an antiseptic, that means it can kill germs, but it can also loosen phlegm. For cold medications, we normally advise to try natural remedies because the cold medications available in the pharmacies have a side effect of increasing the blood pressure. Here are the home remedies for cough, colds, and sore throat. So we advise patients to drink plenty of fluids to stay hydrated. They can use salt water as a gargle. Steam inhalation has been beneficial in terms of moistening the nasal passages. Tea contains antioxidants and substances known as xanthines, which can dilate the airways. Chicken soup specifically contains amino acid cysteine, which can dissolve phlegm or sputum, reduce nasal congestion, and also reduce inflammation. Honey and ginger can help soothe the throat. For diarrhea, we can give oral rehydration salt, probiotics, or advise them to have broth diet. Broth is banana, rice, apple, and tea. These can help harden the stools. Antibiotics is not indicated in this case because COVID-19 is a viral infection. Antibiotics are only reserved for suspected bacterial infections such as in pneumonia or when patients have yellowish or greenish phlegm or inflamed tonsils. For supportive management, we advise patients to drink plenty of fluids or to stay well hydrated, especially for those patients with sustained or high fevers. So how do we know if the patient is well hydrated? So we need to look at the urine and it should be light colored. Fluids also reduce the thickness of the mucus or phlegm. We also advise them to get plenty of rest and sleep. Rest can repair the body and enhance or boost the immune system. For those without difficulty of breathing, we encourage patients to have a physical activity as soon as tolerated during recovery. They should also eat healthy foods and take vitamins like vitamin C and vitamin D and other supplements like zinc. So they can obtain this from foods and supplements. Vitamin caffeine may help protect against COVID-19. And there are studies or scientific studies done on this, like this one, which studies on the role of vitamin C, D, and zinc for COVID-19. It shows in this paper that it enhances the immune system, which is beneficial in fighting infection. Here are examples of fruits and vegetables that are good sources of vitamin C. So examples would be your citrus fruits like lemon, oranges, berries, and vegetables like broccoli, spinach, and potato. So some of these can be found in the food that we eat, but if you are not fond of eating vegetables and fruits, you can take vitamin supplements. Here are the examples of sources of zinc, which includes seeds, nuts, fish. We have seafoods, meat, cheese, berries, and others. Okay, so spinach is also one example here. In Western countries with minimal sunshine and who were also put into lockdown, therefore they cannot go out of the house, they may have vitamin D deficiency. So they may take these food sources which are rich in vitamin D like cheese, margarine, butter, milk, cereals, and fatty fish like salmon. Apart from these vitamins, we can do also breathing exercise, or we ask them to do breathing exercise. Breathing exercise is good for those with a mild shortness of breath to increase oxygenation. So how do we do it? So you ask them to put a hand on the chest and the other hand on the stomach, and try to ask them to breathe in as much air as they can through their nose, hold it for a few seconds, and then release it slowly for about 5 seconds. They can do it 10 times every hour. So, however, if the patients have progressive respiratory symptoms, particularly worsening shortness of breath or difficulty of breathing, then they need to consult their GPs. Stress management is important to keep positive, and this includes meditation, music therapy, prayer, or other relaxation techniques. If you have an asthma or any respiratory disease that requires nebulizer for therapy, try to avoid this because it can aerosolize the virus particles. Instead, use a metered dose inhaler such as this one. For those with concurrent illness like hypertension, diabetes, and high cholesterol, please continue taking your medications. Remember that these diseases are also risk factor for COVID-19 deaths. And also try to avoid smoking. So generally, for patients with mild disease, they usually recover in 2 weeks. For severe to critical cases, which is stage 4 and 5, they require oxygen therapy. So oxygen therapy is started with the arrival of the patient in the emergency department. And this is administered according to the severity of presentation. For mild breathlessness, a simple face mask or this nasal cannula can be used for oxygen delivery. For severe cases, they might have endotracheal intubation and the use of mechanical ventilation. Antiviral agents can also be given. Examples are remdesivir, favipiravir, lopinavir, and ritonavir. These antiviral drugs reduce the multiplication of viruses and improve pulmonary function. Remdesivir is best suited for hospitalized patients with COVID-19 having moderate to severe disease and requiring supplemental oxygen therapy. In Malaysia, the available drug is favipiravir. The third drug is immunomodulatory drug, and this includes tocilizumab, chloroquine, and hydroxychloroquine. Tocilizumab is a monoclonal antibodies. Chloroquine and hydroxychloroquine has received considerable attention as an agent with possible antiviral activity and immunomodulatory function. However, recent randomized controlled trials have shown that there is no specifically clinical benefit or no significant clinical benefit for COVID-19 patients. So these immunomodulatory drugs suppress massive immune response in patients with raised inflammatory markers. Towards the severe or critical stage of the disease, there is increase in inflammatory or inflammation. Antibiotics is reserved for sepsis or for patients with pneumonia with secondary bacterial infections. Corticosteroids can be used for a short period of time in patients who show progressive deterioration of oxygen saturation and also increased activation of inflammatory response. Example of corticosteroids would be dexamethasone, prednisone, and methylprednisolone. Recently, dexamethasone has been found to be effective for decreasing mortality in severe and critically ill cases. Next is the plasma exchange via convalescent plasma. Here, the plasma obtained from the patient who has recovered from COVID-19 contains antibodies that can neutralize the virus in the infected patients. However, there are some important requirements for this procedure, and this includes that there should be adequate amount of antibodies in the plasma of the patient who had recovered, and also their blood type should be compatible. Now, COVID-19 increases the risk of developing clots inside the blood vessels and is further increased in critically ill patients. Therefore, anticoagulation is needed to prevent clotting or thromboembolism. So in summary, majority of COVID-19 cases are mild, that is 81%, 14% are severe, and minority are the critical cases. Among these cases, case fatality rate is 0.6%. That means for every 1,000 person infected with COVID-19, 6 persons will die. And majority in terms of gender are males compared to females. 64% are aged 60 years old and above, which may be due to a weaker immune system in the elderly and also the accompanying other health conditions. 87% are reported to have at least one of these underlying conditions, including high blood pressure, diabetes mellitus, heart disease, high cholesterol, and others. So since majority of the cases are mild, there are no specific treatment, but you can give them symptomatic or supportive management. And this includes advising them to have plenty of rest and sleep, to stay well hydrated by drinking plenty of fluids, take vitamin C and D that can enhance or boost immune system, eat healthy foods, take over-the-counter medications if they have fever, cough, or diarrhea. For severe and critically ill patients, they should be referred for hospital admission because they require oxygen therapy and medications like antiviral drugs, antibiotics if they have secondary bacterial infection, corticosteroids and immunomodulatory drugs for inflammation, and anticoagulants to prevent risk of clotting. They may also have plasma exchange via convalescent plasma. Additional key points: mild COVID-19 symptoms may have resemblance with the flu and the common cold, so it is important to distinguish it. Sudden loss of smell and taste can be an early indicator of COVID-19 and may occur without a stuffy or runny nose. There is shortness of breath that is a warning sign for a severe symptom and may warrant hospital admission. And remember that guidelines for management is continuously evolving as we learn more about the virus and as we develop or find new medicines to mitigate the disease. That concludes my topic, and thank you for listening.
All right. Thank you very much, Dr. Vivian, on the excellent and very educational talk. Treatments of COVID-19 seem to be constantly evolving, and it is hard to keep up with the evidence. You have clarified a lot of things for us today, and I'm sure there are questions from our audience about this topic. So without further ado, I would like to invite the audience to give your questions to Dr. Burbo. Are there any questions from the audience? Oral questions? Okay, if none, I will look at the chat box here. Thanks, Suyin. So published figures suggest that the COVID mortality in Malaysia is lower compared to other countries in Europe and US. What do you think could explain this?
Okay, so I think there are different risk factors that is also involved, and also on how we manage the COVID-19 will differ from different countries, right? Because I think in Malaysia, I think now it's already 0.3%. So in other countries like in Europe and America, I think they started their lockdown a little bit late, okay? And I'm not sure, maybe because we are in tropical country, okay, we are more exposed to other infectious agents. And so I think in terms of our immunity, probably, okay, we are probably stronger. So I am not also, depends also on the structure of the general population. If they have more elderly population, then their mortality will also be high. So those are other factors that can be considered.
Yeah, yeah. Thank you. Next question is, what is the current status of azithromycin for COVID?
Okay, so I've looked into the up-to-date regarding the current drugs that are being used. So azithromycin is actually an antibacterial drug. So it is reserved only if you have a bacterial infections, which you can see probably in stage 4 and 5 when there is pneumonia or secondary bacterial infection. So those are antibiotics that you can use, because I have not specified really which type of antibiotics, because it has to undergo susceptibility testing also, because it will depend from each individual, and also the causative agent for the bacterial infection.
Right. Okay. Next question is there any role for dexamethasone for mild patients at home?
Okay, so dexamethasones or corticosteroids is usually reserved for severe cases because it is mainly used as anti-inflammatory. And I've mentioned that towards the end of the spectrum of COVID-19, there will be increase of the inflammatory markers. Now, if you have known, dexamethasone as a steroid is an immunosuppressant. Okay, so it depresses the immune system. So we don't use it early in the disease because our immune system is still competent. So we don't use it. We only use it when it's already severe and our body cannot cope up with the severe infection. So that's why it's used in the severe or critical phase of the disease.
Right. And then should mild cases at home take thromboprophylaxis?
Okay, so with regards to the use of anticoagulants, these are usually reserved for the severe and critical state where COVID-19 becomes a hypercoagulable state. So I don't think that at mild cases you can take this, because you have also to weigh the benefits from the risk, because these agents can also cause bleeding.
Yeah, true. There's also some other questions in the chat box. Is there a study comparing the efficacy of the common viral agents?
Okay. Well, for the viral agents, they are usually limited in availability. Like for example, Malaysia, we don't have remdesivir, so we use favipiravir. So I have not encountered studies comparing the different antiviral agents, but I have seen studies comparing the dosing for these antiviral agents, like between 5 days and 10 days of giving the antiviral agents, and it showed that there is no difference in terms of efficacy. That's why we prefer the shorter term of administering the drugs.
Right. And then there's a question from Kai Yin Lee. What is the latest evidence of colchicine? That's for gout, right? That's right.
Yes, for gout, because because it's also anti-inflammatory. Yeah, it is listed as one of the possible drugs, but in terms of the evidence, I don't think that it is priority to use or tested. Okay, or the clinical evidence is very significant.
Right. Yeah, very, very interesting. And I think it's a topic that draws a lot of attention and interest from the audience.
Yes, and of course, different guidelines will be, implemented in different countries. Depends also on their how patient responds to the medications.
Yeah. So just out of curiosity, so what is the current verdict on? I know you mentioned briefly about this chloroquine and hydroxychloroquine. So, what is the
Yes,
current
yes.
verdict now? There was a debate going around.
Yes, but based on the studies that I found in up to date, it says that there is no clinical benefit, and
Right.
if you compare the benefit from the risk, you will have more side effects from it rather than the benefit. So it's better to try those with better efficacy, okay, and a safety profile than hydroxychloroquine and chloroquine.
Right.
Yeah.
Okay. Thank you. Are there any other questions?
Oh, I wanted to ask Dr. Vivian, should we all buy a pulse oximeter just in case? Getting a bit scared now.
I don't know, but I mean, some people they buy. I'm not sure how much it is, but I think it's quite expensive. I'm not
You
sure.
can buy cheaper ones, but I don't know how reliable they are. You can spend
Yeah.
200.
And I think also some smartwatch also has a they tell you your SpO2, but
Oh,
I'm not.
can they?
Yes.
Must ask Muhammad.
Yeah,
They
we
wear
can ask. Yeah, some smartwatch they have the SpO2, but I'm not sure also whether it is accurate. So maybe you can check based on the clinical symptoms if you are becoming cyanotic. I'm not sure.
Yeah, this is on the basis that some people are categorized as happy hypoxia. Have you heard of that term?
Happy hypoxia.
You could feel well, but actually your saturation is quite low in the 70s, 80s, 70s.
Oh, yeah.
But they don't feel that ill, actually. I don't know why they don't feel as breathless as they should be, but they actually, that's quite low. So they their risk stratification is quite high. They actually have to go into hospital, but they wouldn't know that.
Yes.
And then there are a few cases also reported here and there that people have turned up, too late dead in or they found dead at home, and actually they had COVID, but they didn't come into hospital.
I think probably if you have one case at home, maybe you could buy one so that at least you can monitor the oxygenation, and also if other people within, your home can also develop the disease, maybe.
I think it's
maybe it's not too expensive. Yeah.
I mean, it's a pretty simple thing to measure and wear. And if you see your sets dropping, you have to go into hospitals, and people might not realize.
Right.
Yeah, that's true.
Yeah, and if you don't have any oxygenation, if you feel like you have like progressive shortening of breath and difficulty of breathing or dizziness, this could be like warning sign. So at least they probably would like to check with their GP and check their auto saturation.
I mean, so now with the home, the quarantine at home type, where if you're sick and positive, you quarantine at home. Presumably, that's only for people who have an isolation room, right? That you
Yes.
It is quite hard to ensure that you don't spread it to other members of the family. You have to be really strict about staying in your room. I mean, I think it's a good move. I don't know. What do you think about that? Do you think that's a good idea?
I think it is.
Hospitals.
Yeah.
Yeah.
To reduce the burden on the healthcare.
Yeah, and
that's a necessary measure, I think.
Choice about that, but it is a little bit scary when you have to monitor yourself.
Correct.
And what about the thing about lying on your stomach, lying face down?
Self-proning. Yeah, I think that can also improve the difficulty of breathing, and also improve they call that the pulmonary drainage. So it loosens, like if you have excessive phlegm, okay, that could loosen out.
That's something you could do.
Right. Yeah.
Okay.
So last chance. Any questions? Oh, there's one in the chat box. Yeah. In terms of vaccination, is there a verification process between vaccination positive for COVID-19 and infectivity of COVID-19 virus itself?
I'm not sure how to answer this. Maybe Prof. Chong.
I'm trying to understand the question.
Yes. In terms of vaccination, there's a verification
process between vaccination on vaccination positive
and infectivity. I mean, how do we differentiate whether it's from the vaccine and not from the infection? Is it?
Zaida, do you want to unmute yourself and clarify your question? How do we verify in terms of that?
Could be asking about the serologic testing if you have a serology after you have the vaccine.
In terms of lab method. Oh. Okay.
Could this mean that you're positive because you're previously infected, or you're positive because of the vaccine? Is that right?
Oh yeah.
Oh,
I think so.
I see. Yeah, that's a tricky one. So after the vaccination, but there's usually a time point. So after you receive the vaccination, there will be a lack of there will be a period for your body, the immune system to react, for the immunoglobulin level to build up. So you have to look at the dynamics as well, and the period of interval between your vaccination time and also the time when you detect the antibodies and which subtype of antibody as well, the IgG or IgM, So yeah, for that, you have to look at these various parameters, the subtype of the IgG, and also the timing when your antibody levels actually get detected relative to the time that you got your vaccine. So I hope that answers your question, Zaida. All right, thank you. Are there any more questions? We still have a little bit of time. Yes. If there is no more question, then I would like to thank Dr. Vivian Verbo once again for your really, really informative and educational talk. So we have now come to the end of the afternoon parallel sessions, and I would like to thank everyone for their active participation, including our audience. So this has been a very educational session, and so I extend my deepest gratitude to all our speakers and the presenters for their great talks and valuable research contributions to the public health field. Please, can everyone connect back to the main Zoom meeting room now for the announcement of winners and also the closing talks. So thank you, everyone.
Thank you, everyone.
Thank you.
Thank you. Oh, just before you leave, provide the feedback on the Google form.
Yeah.
Yes,
I think I need to copy the feedback link.
I'll leave. Thank you, guys. Thank you, Prof. Chong. Thank you, Dr. Verbo, and all speakers.
Thank you.
Thanks, Swin. Thanks, Dr. Vivian.
Thank you, Prof.
Thank you.
Bye. I'll see you in the main room.
Yeah.
Okay. Bye.
Okay, bye.